Hello.
No, ma'am.
Now it is live.
We are live now.
Should I start, ma'am?
Yes, yes.
Yes. A very good evening to all the dignitaries on this platform. Respects to our chief guest, Dr. Rishikesh Pai, our dynamic president, Foxy, and regards to our guest of honor, Dr. Firdausi Begum. Revered President Safog, Dr. Ruhana Hotatua, and an amazing organizers, the General Secretary, Dr. Yusuf, Chair and Co-Chair, Dr. Padmaraj Pant and Dr. Sadhana Gupta. My greetings to the most learned faculty, our chairpersons, Dr. Jaideep Malhotra, Dr. Samina Chaudhary, Dr. Harsha, Dr. Pratibha Singh, Dr. Shyam Desai, and Dr. Laila. Our speakers, Dr. Sadhana Gupta, Dr. Rupina, Dr. Indu Asanka Jayavardhane, Dr. Rakhi Singh, Dr. Farhana, and Dr. Hema. My warm and hearty welcome to all the attendees who make all the efforts fruitful. At the outset, I would like to invite our president, Safog, Dr. Ruhana. Dr. Ruhana is the founder chairman, 9 Wells Care Mother and Baby Hospital, Colombo. He has been Secretary General, Asia Oceania Federation of Obs and Gynae, and immediate past chairman of Menstrual Disorder Committee, FIGO. Sir, you are invited for your welcome address. Over to you, sir.
Thank you, Dr. Amrita, for that kind introduction. And I thank Dr. Sadhana Gupta, our co-chair of the NCD committee, and Dr. Raj Pant from Nepal, who is the chair of the committee, for organizing yet another webinar from this NCD committee. I mean, and they have chosen a very important theme, that is on Pcos and metabolic syndrome. So I am sure that today we will be in for a very big treat on this subject. So I like to welcome, I think, Dr. Rishikesh Pai, the Foxy president, who was inducted very recently. I think, as I was told, we were told that he'll be joining very shortly. So we are very thankful to him for being coming as the chief guest to this ceremony. And then we have our Professor Firdausi Begum, who is our immediate past president, who is here as the guest of honor, and we welcome her. Also, she has been very, very helpful and very active in all our programs. And we have with us Dr. Shyam Desai, who is the incoming president of our Safog. He too is very active in our federation, as takes part in almost all the activities, and his assistance is greatly appreciated. So we have a real galaxy of leaders from this Safog region, whom I think Dr. Sadhana Gupta has been able to gather. And so we are very happy to see all of them. So I will go through them. I can see Dr. Jaideep Malhotra and Dr. Laila Ajpun Banu, Dr. Samina Chaudhary, our Professor Farhana Devan, who is our Deputy Secretary General in Safog. And I must especially mention, because she has been very active in our Safog activities and has played a very major role in helping us to organize them. So I'm very happy to see all of you. And so today there are very special lectures delivered by Dr. Sadhana Gupta and Dr. Rubina Sohel, and also then there are the country perspectives delivered by the Dr. Indu Asankar, Dr. Ricky Singh, Dr. Farhana Devan, and Dr. Hema. So we are, we all can expect a very good webinar on this subject, because PCOS, as we know, is very common thing in this the South Asian Safog region, and about I think 6 to 10% of our women are suffering, and it is very special because the South Asian women, tend to get these symptoms much earlier than the other Western population, and also some of the features are much more prominent in our women, like the hirsutism, the insulin resistance, and so on. So there are so many things which differ from the Western population. So I think these will be discussed, and it will be very good for us to. So I can see Professor Rubinas Sohail also joining, and I must also mention he is also a very live person in our Safog community. So she has been very helpful in most of the activities. So without taking any more time, I will hand back to our moderators to continue with this webinar. So thank you very much for everybody for joining and making this webinar a very success. And once again, I thank the two organizers, Dr. Sadhana Gupta and Dr. Fat, for coming up with another webinar. Thank you very much.
Thank you, sir. Thank you for your wishes and blessings. And we have our General Secretary, Dr. Latif Khan, who is the Professor of Obs-Gynae in Rashid Latif Medical College. He has written many textbooks in gynecology and many other books on infertility, ultrasound, ovum pickup, and has been the achiever of many awards. He is much into infertility, but he is our General Secretary, Safog. Dr. Padmaraj Pant is the Chairman, NCD Committee, HOD, Department of Obs-Gynae, Tribhuvan University, Maharajganj, Nepal. We have Dr. Sadhana Gupta, who is the co-chair, Safog NCD Committee. She has been the representative to Safog from the year 2018 to 2021. She has been the vice president of FOXY in 2016, also the ICOG Governing Council member. She is the achiever of so many awards, a great leader and a great academician. Madam Dr. Pai sir is not here, so let's proceed.
Yes, yes, for the Pardosi, Dr. Pardosi.
Okay. We have with us our guest of honor, Professor Firdausi Begum. She is the Professor, Department of Obs-Gynae, Ibrahim Medical College, Dhaka, Bangladesh, which is an institute of women and child health. She has been the immediate past president of Safog, President Gestosis Society, Bangladesh chapter, member Technical Subcommittee, Women's and Children's Health, WHO, associate editor of International Journal of Gynae and Obs, co-chair editorial committee, member of FIGO Committee of Childbirth and PPH. She has more than 85 publications to her credit and written more than 10 chapters in textbooks. Over to you, ma'am, for your blessings. You're welcome on this platform. Yes, ma'am.
Good afternoon, everyone. Thank you for inviting me, and Bangladesh has good participation and all Safog countries. Hi, everyone. It's a fantastic afternoon for all of us and evening for many of us as well. I think as I have chosen the subject of polycystic ovary syndrome during the Safog conference in Sri Lanka, as probably you remember the topic, combating polycystic ovary syndrome in adolescents in Safog countries. So that shows the importance of polycystic ovary syndrome. And the link between metabolic syndrome and PCOS is proven, number one. And it has to be taken care of from the very beginning of the life so that the metabolic syndrome can be avoided as much as possible in later life, because it's a known complication of or long-term sequelae of polycystic ovary syndrome. And I congratulate and thank the organizers for choosing the right topic at the right time. And I think that's the important thing we need to take care. And it is obvious that the lifestyle of the people has changed over time. And now the people move less, eat more, and eat not very healthy food. So that's the fact now. And we know the other fact as well, that we have to move away from this. So our effort will be concentrating and focusing on this chapter. We have to have more research on our area, in our region, regarding all these factors, and of course the implementation researches, that how we can basically work actively and effectively to move away from this disastrous behavior of us, which leads to very worse consequences. So I think there is a big group and sort of people who can work in the policy level at different level of healthcare system. So if we can work together, I think we can combat this and basically work something very significant and positive. So I again thank the organizer for organizing this. We are here to participate as well as formulate applicable recommendations so that we can really work on this and come out of this disastrous disease and consequences. Thank you, everyone. Thanks.
Thank you, ma'am. Thank you for the words of wisdom. So now we are quickly moving on to the scientific session. PCOS, we all know, is very common, is the commonest endocrinopathy of women in the reproductive age group. It's a constellation of reproductive and metabolic abnormalities as on anovulation, hirsutism, acne, and insulin resistance. South Asian PCOS women have more symptoms in comparison to other ethnic groups and also seek care at an earlier age, having higher degree of hirsutism, infertility, and acne, and they also have lower live birth rates. Inheritance, of course, has a genetic basis, and ethnicity, lifestyle, and environmental factors play an important role. So the theme, breaking the nexus of PCOS and metabolic syndrome in South Asia, is very, very apt for today's webinar. So for the first talk, which is Adolescent PCOS, Beware and Be Aware, is to be spoken by none other than Dr. Sadhana Gupta. And for this, I would like to invite the chairpersons. It's my privilege to introduce all the empowered women representing their countries. Professor Samina Chaudhary, Madam, you are invited. Madam is the chairman, OGSB Hospital and IRCH. She's the past president of Obs and Gynae Society of Bangladesh. She's the president, Endometriosis Adenomyosis Society of Bangladesh. She is the active ambassador to FIGO, master trainer of PPH Bundle Project Bangladesh. And she is also the editor of Bangladesh Journal of Obs and Gynae. She has more than 80 publications, authored 5 books, and contributed chapters in textbooks. Our second chairperson is Professor Jaideep Malhotra. She is the managing director of Art Rainbow IVF, Vice President, Indian Society of Aesthetic and Regenerative Gynecology, Chair, FIGO Committee of Reproductive Medicine, immediate past President of SAFOMS, Regional Director, South Asia, Ian Donald School of US Ultrasound, Professor Dubrovnik, International University at Croatia, Editor-in-Chief, Safog and SAFOMS. She has been the past president of all the Indian organizations related to gynecology, FOXY, ISAR, ASPIRE, and IMS. recipient of many, many awards, many publications, invited faculty to all the national and international conferences. So over to chairpersons. And at the outset, I would request Madam Chaudhary to introduce the subject and the speaker. Over to you, Madam Samina Chaudhary.
Greetings from Bangladesh. First of all, I am very much pleased that you have honored me as a chairperson of this prestigious session. And this is a very common subject nowadays in reproductive age, that is PCOS, and which is a very complex endocrine, metabolic, and genetic disease affecting the reproductive life of. And the incidence varies from country to country and varies from 2.5% to 12%. But nowadays, we are observing that it is increased day by day. And maybe the factors related to lifestyle and also the environmental factor also added with it. And which is a common cause of infertility, that for that we are here today. And this is also manifested by the obesity problem, ovulatory dysfunction, androgenesis, and also high insulin resistance. And also there is a very important risk of metabolic disease, metabolic syndrome or X syndrome. But I think in this meeting, we'll discuss many things, many aspects will be enlightened here on PCOS. But I want to mention one thing, that today is the 15th November, the World Cord Blood Cell Day. The cord blood cell, you know that it is very much rich in stem cell. And researchers now working on regenerative medicine with the help of this stem cell and can develop and appropriate treatment for PCOS in animal model. And human bone marrow mesenchymal stem cell and their secretome has got the anti-inflammatory property on various systems. And so it ameliorates the metabolic dysfunctions, steroidogenesis, and restores fertility. And it reduces the insulin resistance and androgen production. So I think in future, there is a good hope that we can use this stem cell therapy for PCOS. By this, I want to introduce our beloved Dr. Sadhna Gupta. Please show me the CV of Sadhna. First of all, I want to introduce with Sadhna Gupta that she is born with the gold medal. And she is the co-chair of Safog NCD committee and FOXI representative to Safog, Vice President FOXI, and also ICOG Governor Council member with the Best Governing Council Award. And corresponding national editor and peer reviewer, Journal on OBGYN India, and Journal of Safog. FOXI, first chairperson FOXI Safe Motherhood Committee, and also she had 4 times best AICOG research papers, and she is honored with the national and international forum of exemplary work done to reduce the maternal mortality and many aspects on this issue. And she is the director and senior consultant of OBGYN in Jivan Jayati Hospital and Medical Research Center.
Thank you.
With this,
Thank you.
I want to invite you to present your paper on
Thank you.
adolescent issues.
Thank you, Dr. Sabina, for generous introduction. Dr. Pai has joined from the Thailand, and we are very grateful to him. And with the permission of Dr. Sabina and Dr. Jaideep, can we have the Dr. Pai's address before I start my talk? Dr. Sabina and Dr. Jaideep, your permission. Dr. Sabina, can we go ahead with the Dr. Pai's address? So it is a pleasure to introduce Dr. Pais, and Amrita Abhishek, kindly flash the CV of Dr. Rishikesh Pai, who has been like a known figure. He is like an elder figure for all of us, always helping, and I will really like to have his formal CV. He is present medical director, Bloom IVF, administrator, Foxy Manyata Initiative. We have come a long way in a joint journey of Foxy Manyata, and the director, corporate affairs, IFFS, adjunct assistant professor at USA Virginia Medical School, postgraduate teacher, and the DNB examination, visiting professor in Manipal University. And he is known for his immense work in the infertility, and what he say, he always pulls future into present by his always enthusiasm in the investment of knowledge and investment of equipment. He really forces us to look into the future and to work for the futures. He is present Foxy president. He has just took over in the 23rd October in a grand ceremony, and is all going on to the people, reaching people for the women's health, awarded with 30+ award, including prestigious Lifetime Achievement Award for outstanding research in reproductive health. A very ardent and the strong and speaker, editor of over 16+ books and the numerous research publication to his credit. So we welcome Dr. Pai on this Safog platform, and we request you to deliver your chief guest address.
Thank you, madam. I hope I'm audible. Thank you, Dr. Sadhana Gupta. I would like to recognize Dr. Rohana Hatatua, our Safog president, and Dr. Rubena Sohail is there, and Dr. Firdausi Begum, Dr. Jaideep Malhotra, and our next Dr. Sham Desai is also around, and there are a lot of other people like Dr. Lalita Banu, Dr. Samina, Dr. Jaipuria. I can see Dr. Pratibha, Rakhi, Jayavardhane, Srivastav, Dr. Pant, all of you. I saw, and Dr. Please excuse me if I have missed out on any other name. Actually, I'm here for the Family Planning Conference. It is called the International Conference on Family Planning. There are 4,000 people here, But, me and Dr. Jaideep Tang were here, and we were laughing because no one knows us here. Because, we are normally used to getting known, but this is a totally different world altogether, family planning. And, I was on a panel, and I was telling them that, in the last 30 years, when my dad was from Harvard, and he was the director of family planning, started public health in University of Mumbai. So when I was a young kid, I was very fascinated. He had started the first laparoscopic training program for Asia. They used to come, people come all over the Asia used to come to our hospital. We had the first laparoscope in a country we had got, and he used to train them in laparoscopic sterilization. So that time the technology of family planning was very aggressive, and that's why people were very. Now what happened down the road in the next 30 years, we got laparoscopic surgery for other areas. We got IVF. So we got, I was telling all of them in the panel in public health, there are a lot of people in the audience. I said, what happened is we gynecologists started getting sidetracked because we always are attracted by technology. And, I said, if you have to bring the gynecologist back to the mainstream of family planning, you need to implant family planning. You can't have hardcore family planning. You need to implant it in their day-to-day. It has to be juxtaposed with their day-to-day life, so that it will, because the family planning is a very important aspect of our world. Climate change is all because of the population explosion, and we should refocus on that topic all the time. So as a president of the federation, I have my slogan is happy woman, healthy woman. So healthy woman is a happy woman, and my CSR slogan is Badlav, that is change. And it is defined by 3 aspects. One is integration of thought. Second is equality. So, if you look at international language, it is called equity, but in our countries, they will not understand equity. They'll think it is a stock market or something. So I coined the word equality rather than equity, which would have been more appropriate. And the third part of my slogan is technology, utilizing technology to achieve that change. And so integration is right from womb to tomb. So we have to integrate. So I feel that whenever we touch someone, we should tell them about what is available to them in form of new technology, so that they are aware. Unless they are aware of what is available, how will they demand for that technology? So we are creating a 12-minute cartoon film which will tell them about right from how they are born till the time they are in their midlife or menopausal years. What are the things that they can have? What are the things they should do? So this is in a form, and we have launching, and so I'm starting my journey. It's a journey of communication and outreach. So we are starting it. It's called the Yatra, and I'm starting it from, we have a place up in the north in Uttarakhand. It is called Rishikesh. My name is Rishikesh. So from the banks of the river Rishikesh, on the 20th of November, we are starting that journey, and we are going 3,300 kilometers. We are touching 20 cities. Every city I'm doing a camp of 200 people. And we have recently the government of India has done a survey. It is called NHF5, National Health Survey number 5. And all the parameters of the NHF5 survey will be we'll find out what is happening. We'll collect their blood. We'll do all the parameters. We'll publish what is happening to that 3,300 kilometer journey. What is happening to the patient? And so that journey has got three components. One is the camp. The second component is the public forum. And the third component is the CME, which is there in the night. So it's a very exciting journey for me, because obviously the other things. So if you look at life for an association, there are 5 parameters that you always focus on. One is academics. It's a default for all of us. The second part of the association is obviously fellowship. We are all friends. If there is a problem, we should at the middle of the night leave everything and help our fellow. I feel that fellowship is the thread that stitches the association together. And third part of this is advocacy. We gynecologists, especially in our Asian region, we lack it. So if you look at the United States and all, they're very aggressive in their advocacy. They talk to the member of parliament. They'll advocate. So we must be more connected to our legislators, because the legislators can influence our practice and they influence our patients, how they get treated. So advocacy is very important. The fourth part of an association is what is known as research. It's very important. So we are trying to start multicentric trials. I'm launching 5 trials. If you look at the citations from the third or the developing country, always a paper which is a more descriptive paper, where data analysis, that those papers are cited more, because otherwise our countries can't spend money in basic hardcore research. So we must focus on more public health related research, so we get more citations for our papers. And the fifth part of the program, which is the most important part, obviously, is CSR, is social work. So these are the 5 parts of the program, and there's a sixth part also to the associations, and that is business development. We must develop the practice of our fellows. And what has happened is, over the years, because there's a contraction in world economy, and most of us are private practitioners and we are directed to the private segment, we are having a lot of contraction, and we need to now look at newer avenues of business development. For example, we must have the adult vaccination program. The pediatricians have the pediatric vaccination. Not only it helps them in doing social work, but it also helps augmenting their income. So we should now devise an adult vaccination profile, which should be advocated when a patient comes to a clinic. Similarly, we should have other areas, and one of the big areas which I am thrusting in my presidency is the NCD area. So now I'm not talking about pregnant women with diabetes. I'm talking about non-pregnant women with diabetes. I'm talking about non-pregnant women with hypertension. This is one area where the preventive health area is one area which is now vacant, and the Gynecologist Association have to take over that area, because the surgeons and the physicians are very busy implementing curative services. So we must now look at the NCD area in the non-pregnant woman, not the pregnant. Pregnant women is our area, no one can touch it. But the non-pregnant is one area which is virginal, and this area has to be taken over by the Gynecologist Association. And in my year, I will thrust in that direction. I've already chalked out the plan and all the clinics, because it is important. It is my obligation as president to see that my fellow colleagues, they increase their practice as well. So these are the 6 parameters of an association, and all the 6 parameters have to be looked at. And we all in the Safog, we are all friends, we are all neighbors. We have to help each other in times of crisis. Forget politics, forget religion, forget government. It doesn't matter to us. We are ultimately bond. I always said that the most important parameter in the 6 is the thread that stitches us together, and that is the thread of fellowship. If Dr. Samina wants some help, I have to get up and say, yes, I will give that help. And similarly, vice versa. So that is how fellowship goes. And I hope that we all always remember that. That's the most important. All these academics and all this all secondary. So fellowship is the most important part of relationship. And I wish you the very best from Bangkok, where the family planning movement is very hot. Contraception, implants, how to do it. All the agencies are there. The Bill Gates Foundation, the USAID. We have Indian leading the USAID now. Atul Gawande, who is from Harvard. I just met him yesterday. Fantastic orator. So all these people are there, and I wish you the very best. Thank you very much.
Thank you, Dr. Pai, for giving such a good vision what a professional body should have. And we look forward as a Safog country, what we say, we look forward always for a great association. Thank you for joining from a distance. And we really, it's good to see that you are in a family planning, being an ardent infertility specialist. So have a great time. And with this, I seek permission to share my screen for my presentation.
Thank you. Bye-bye.
Thank you, Pai, sir. Sadhna ma'am, please continue with it.
So with this, yes. So coming to the talk, adolescent polycystic ovarian syndrome and why it is important. Dr. Fardausi Begum have already said that the adolescents are the thing in the South Asia, the age target where we have to work together. So thank you for being together. In my journey in Safog, it is one of the most contending and a relaxing tenure and the period we had with the beautiful people, all the 7 nations of the South Asia. And PCOS is a global phenomena, and it is not now belong to only urban, only rich. It is seen across race, across ethnicity, across country of origin. And the important adolescent health related quality of life. So this is very important. PCOS is just around this. Most frequent endocrinopathy in women, and what is the prevalence in adolescence? We actually don't know, and why we don't know, we will just look into the many diagnostic issue and many like regional and any ethnic issue, but overall it is not less than 1%. And when we in South Asia, we have a huge, like 15% of our population is young, and we are fortunate about that we have the young population. But if 1% is 1 or 1 to 2% PCOS adolescent, that contributes to a good absolute possibility of PCOS in the adolescents. So we know we have come a long way from Steele-Leventhal syndrome when he recognized that the oligoannulation, hyperendogenous obesity to infertility, that it is now the insulin resistance. We think that it is the basic cause which cause all disturbance in steroidogenesis, hyperandrogenemia, and the anovulation. So this is all what we know till now, though there have been many major emerging concepts which is actually focusing into the new causes and the new etiopathogenesis of PCOS in current time. So it is insulin resistant, which cause hyperinsulinemia, which cause the increased insulin receptor on stromal cell, which cause the hyperandrogenemia from the ovary and decreased sex hormone binding hemoglobin XHBG, which cause the increased testosterone and cause finally the increased LH and the decreased FSH. So it is the basic pathophysiology which up to now we consider what causes PCOS, and why we are focusing on adolescent, and I will say not adolescent but just pre-adolescent also, because why we as South Asian have got the different varieties of PCOS and the higher chances of PCOS also, because we are having the intrauterine growth retardation more in this region. When this intrauterine growth retardation baby is born and fed well, then it results to childhood obesity, then premature puberty. And if they are having the genetic predisposition, we are more chances of getting our adolescent with the PCOS, with the classical picture of anovulation, oligoanovulation, and the hyperandrogenism. So why it is different in adolescent? Because as adolescent are something always mixed, always haywire, the presentation of PCOS in adolescent is also not classical, and here lies the role of an alert clinician, that how in a busy OPD we come to know that this girl can have the PCOS and it should be screened for the PCOS. So why there is an issue? What we say that when we see the gynecological perspective, we see from the different eye, because we say she is a young woman, but when the pediatrician and the adolescent society says, they see them as a child. So we have a lot of guidelines and a lot of recommendation from many professional bodies, and it is time that we all speak the same thing. Why the difficulty of diagnosis of PCOS? Because adolescent is a transitional stage. They are in making. So many features of the PCOS, symptoms as well as sign, can correlate with the normal adolescent development. They have the immature hypothalamo-pituitary axis. We always do ultrasound abdominally, and the characteristic, that is the menstrual irregularity, can be a normal sign of the adolescent. So we have to be very clear that when we say that this girl should be screened for PCOS or it is a confirmed PCOS, we take the full consideration of all the diagnostic modalities and a good implementation. So PCOS is all about genetic, dermatologist, diabetologist. They can go to many specialties, and the adolescents always, what I like to say, that acne are common, weight gain is common due to many reasons, thyroid and prolactin disorder very common, they are stressed out also, and the imaging can be suboptimal. So adolescents are different, and are we confused or clear on the diagnostic modalities of PCOS in adolescent? I will just like to cover in next 10 to 15 minutes. So adolescent PCOS is a different, and why this diagnosis is important. First of all, that if we miss the diagnosis, we will lose the opportunity to all positive lifestyle intervention as well as the pharmacological management. But we overdiagnose adolescent PCOS, then it creates a lot of anxiety to the girl and the family. And here we are having this topic, breaking the nexus of PCOS and NCD. And in South Asia, we are really struggling with the tsunami of non-communicable disease, and adolescent and the pre-adolescent age is the right time when, as a OB-GYN, we can do the right intervention so that they don't have all these long-term implications of the PCOS. So we have to be very careful in diagnostic criteria and the re-evaluation of all these adolescent girls so that we follow them. So what is the complexity of defining and diagnosis? So we know all the NIH criteria, Rotterdam criteria, Androgen Access Society of criteria. But one message I want to give to all, that in adolescent PCOS, we have to fulfill most of the criteria or all the criteria. So it is Sultan and Paris and output of oligoanovulation, clinical hyperandrogenism or biochemical hyperandrogenism, insulin resistant, and PCOS. Sultan and Perry says at least 4 out of 5 criteria should be fulfilled when we say that this girl is having PCOS. And for the Rotterdam criteria, all the 3 criteria should be there. So the threshold of the diagnosis is a little high. Don't diagnose the PCOS in a very hurry or in the first visit. So the second thing is what is normal. Now today's question is what is normal in every field? What is normal blood sugar? What is normal weight? So for adolescent, the menstrual irregularity can be normal for 1 to 2 years. And before we say that a 14-year girl comes to us, she is having 2-month amenorrhea, and we say, oh, it is PCOS, because there is so many academic meetings and the webinar. So we have to think that it may be normal because of immature hypothalamo-pituitary axis. And when we should think that this girl should be screened for PCOS, when there is a more than 2 years oligoanovulation, delayed menstrual cycle, or from the very beginning, it is more than 90 days. So even in first year, if the girl is having more than 90 days menstrual cycle or less than 20 days, these girls should be screened for the PCOS. So we have to be very clear what is oligoanovulation, what is menstrual pattern for these girls in adolescent when we think that this girl should be screened for the PCOS and the further investigated. So delayed menses, nowadays we are seeing a lot of girls who are having delayed cycle and they respond to estrogen, progesterone or the hormonal withdrawal reading, but these girls are having very high order PCOS and a lot of issue with this. So this is the new entity which we are really seeing in our day-to-day practice. Insulin resistance, yes, it is the basic of PCOS, but it can be common in healthy adolescent. I want to emphasize that insulin sensitivity decreased by about 50% with increase in insulin secretion, which is a normal. But the girls who are having the PCOS, they have the higher insulin resistance. The one important thing that always ask that their parents are having any metabolic disorder like hypertension or diabetes, and if they are overweight, now these girls should be screened for the PCOS. So this is important that insulin resistance, a little amount, the little level is a normal for adolescent, but if it is a obesity, the parental history, then we should think that they should be screened for it. Hyperandrogenism, this is very important because in our country, I see at the very beginning, they like write a lot of costly investigation. So for South Asia, we have to be very, very economic minded because we have the limited resource. Our patient also have the limited resource. And that is very important that we should judiciously use any investigation. So one message I want to give that the clinical hyperandrogenism, that is severe inflammatory acne, very high hair growth, then we can take it as a clinical criteria of hyperandrogenism, which is as good as the biochemical hyperandrogenism. So when we want to have the biochemical hyperandrogenism level estimation, then the total testosterone, free testosterone, that should be there. Sometimes total testosterone does not get the good result. Yet it is important that we understand our limitation because there is diurnal variation, and if it is a persistent total net testosterone more than 90 microgram, then it consider androgen axis. Another important thing which I wish to communicate, that only isolated finding of biochemical hyperandrogenism and the girl is having no clinical sign, these girls are not for the treatment. Yes, they can be screened, they can be followed up, but it is not the diagnostic, it is not the diagnostic criteria for the PCOS. And the second thing is that we have to have the good laboratory standards for these testosterone estimations. So good reference value is very, very important. So this is important slide, like the recent recommendation that isolated mild hydrocephalus should not be considered the clinical evidence of hyperandrogenism, but moderate to severe hirsutism constitute the clinical evidence of hyperandrogenism. If the girl is having acne, severe inflammatory, they should be screened for hyperandrogenism before they go to the cosmetic treatment. And when the single androgen level is more than 2 SD above mean for the specific assistant, then it should not be considered for evidence in otherwise asymptomatic adolescent girl. So this is very, very important because it is a costly test. It is a dicey test that we screen. We select good girls who really need the biochemical confirmation of hyperandrogenism, and the clinical hyperandrogenism is as good as the biochemical level. Third point I want to give, that the AMH level should not be used to characterize PCOS in adolescents. So this is very important, because we don't know what is a normal AMH value for the adolescent, which we say nowadays, and it is always a diagnosis of exclusion. So non-classical adrenal hyperplasia is the thing which we have to exclude. And of course, every girl for the oligoanovulation, thyroid, and the prolactin disorder has to be excluded. So it is important that we judiciously use these all hormonal tests. For adolescent girl, the ultrasound morphology is a big question mark. We have a good machine. We usually do the abdominal ultrasound. And one takeaway is that it is more than 12 cc volume of ovary, and the ovarian volume should be measured. One message is, and it is not the multifollicular pattern, but it is more than 20 follicles after 7 or 8 years of menarche, then we consider that it is a ultrasound polycystic ovarian morphology. And ovarian imaging should be deferred during diagnostic evaluation of adolescent PCOS at least up to 7 years after menarche. So this is very important that we understand. Every girl here and there is coming with the self-reported diagnosis. I am having PCOS, I am having cyst, but we must understand that ultrasound morphology has to be taken very carefully, and it should be done at the right time. So PCOM, obesity, insulin resistant, severe cystic acne, and biomarker, they are not recommended for diagnosis of PCOS, but it is oligoanovulation and the clinical and biochemical evidence of hyperandrogenism. So I really wish to give all message that we should be very clear that what is not recommended, AMH not recommended, exclusion of other disorder is recommended, and menstrual cycle reevaluation should occur 3 years post-menarche, and ultrasound reevaluation 8 years post-menarche. And biochemical hyperandrogenism is as good as the clinical, and clinical hyperandrogenism is as good as the biochemical hyperandrogenism. So finally, the last question in which all clinicians are interested, that is how to approach and how to manage adolescent PCOS. We have to screen which girls are having high risk for the PCOS, and how to demonstrate with the different labs. Always, whatever technology is there, the basic clinical acumenship is the basic thing, and the cool and the compassionate approach to these girls. Take good family history, good menstrual history, menstrual calendar, physical appearance, personal history, where she is studying, she is having any examination, she has shifted to hostel, because that causes a lot of hormonal disturbance, and what are their secondary sexual character, and what are the signs of insulin resistance. So look well, listen to these girls. This is very important, and it remains the cornerstone of the further investigation. We have to exclude the other causes, which I said already. And once the PCOS is confirmed, now this is the Safog and CD committee webinar. So we want to break the nexus of adolescent PCOS and then NCD in the future, in the adult life. So it is fasting level or the random blood glucose level, and the fasting insulin may miss many PCOS girls. So we need glucose challenge test, and that should be fasting and 2-hour PP or 2-hour 75-gram glucose challenge. And the lipid panel should be done only in obese and overweight adolescent PCOS, or the family history, who are the parents or the family have the history of dyslipidemia. What are the adolescent markers for the metabolic syndrome? These are blood sugar level fasting more than 100, high density lipoprotein less than 40, and triglyceride more than 110, and the waist circumference ratio. So blood pressure, many times our sister and staff fail to take blood pressure because these are the young girls, but blood pressure has to be taken because we have to consider the other cause of hyperandrogenism also. So that is important. How to approach a big question. It is lifestyle, better, very easily said and very difficult done, and the pharmacological agent. So one message I wish to say, as a South Asian country, we have to look now with that emerging concept that look for the weight gain in the pre-adolescent period, because that is very, very important, that the pre-pubertal metabolic dysfunction may be one of the first phenotypic trait observed in adolescent girl, and the lifestyle intervention to be started not in the adolescent, not at the menarche, but like we say around 7 to 11 years when the child is gaining weight. And that is the time when we teach the parents that what to do, good quality of diet and the balanced diet and the exercise. So this is very, very important that we look into this. Lifestyle intervention remains the first line. And the second message wise is always say the reduce weight, and a girl is not able to reduce. It is not the weight reduction only absolute, it is the quality of diet which is very important. And it is a next emerging concept, that is a dogma theory, which says if we take the diet, what junk food, more sugary food, more cold drinks, that disturb the gut permeability and cause the gram-negative colonic bacteria lipopolysaccharide into systematic circulation, that cause chronic inflammation, and that cause insulin resistance. So this is our new understanding with the dogma theory. And what we say in South Asia, what we eat, what we become, that we should focus on the quality of diet and what should be the diet that is low saturated fat, low GI, low sugar and high fiber and high in essential fatty acids. But how to do? We have a lot of things to know, but when the celebrities are selling junk food, there are so many advertisements, so many like Carrie, and you order the food, everything is on your hostel in your room. So it is a tough fight for all of us. COC correct the menstrual irregularity, they correct the endocrinopathy also. Just one message that as per the girl requirement, if she is having acne, then hirsutis, that the cyproterone acetate combination are considered better. And if the girl is overweight, then the drospirenone. It is something temporary measure to menstrual cycle regularity and the correcting endocrinopathy. But again, question is this, in adolescent, how long? In our region, actually, parents are also skeptical about it, but they are right also. So how long COC, if we took 1, 2 year or 6 months, even possibility of cessation of growth in perimenarche GERD, what is long-term consequence in fertility, post-pill amenorrhea, and lowest possible estrogen in a GERD with migraine headache. So these are issues and the questions before us. Progestin we can give for the withdrawal reading. Just one message that they don't correct the endocrinopathy or PCOS. So it is a temporizing measure to resume the menstrual cyclicity, so that we have the predictable pattern for the menstrual cycle. Insulin lowering therapy, metformin, we have a lot of experience. It is the most effective insulin sensitizer, most experienced also. We can start with 500 milligram OD, but important thing, there are a lot of issue with appetite, and we have to have the watch on the liver and the kidney function, and many people don't able to tolerate it. So metformin is one thing we have experienced, and now the inositol has come in a big way, which act as a second messenger on the insulin receptor. We are using a lot inositol in adolescent because they are just nutrition. They are not having any side effect. And it is we still need long-term studies that how the inositol are good, but the world is looking for the nutritional therapy for all endocrinopathy. So prebiotic, probiotic, inositols, DHA, many things are being studied very, very extensively, because it is a disease which has been caused by wrong nutrition, and the right nutrition and the right nutrition supplement can really correct it. It is a big question. So the nutritional treatment of the PCOS is a thing which we have to look together, and we are still being used, and we are having quite a good result. We can say a quite satisfactory result. Anti-androgen as a gynae, we don't give it. There are issue of the toxicity as well, but whenever there is a hirsutis which is not responding to cyproterone COC combination for 6 months, then we should refer it to endocrinologist. So the combination therapies is lifestyle, followed by insulin sensitizer. We will say inositol as a first choice and a metformin as a second choice, but let's discuss with the chairperson. always and always look for mental health. These girls, actually, as a medical person, we tend to give them a lot of stress. You are so like fatty, you are not looking good, and you look like, and there are a relationship issue. They are in a many competitive exam, career issue. So we have to look for this and be assured that you don't increase their mental stress by so many restrictions. People try for everything, especially in our area. We really try everything, but still we don't have any answer for it. A lot of research gap, what our Dr. Rohana, Dr. Fardowsi, Dr. Pai asked about the future research in PCOS, and there are a lot of research gap which we can do together. So we have to be very careful. Adolescent PCOS is very much around us. We have to give the good diagnostic criteria. We don't either have to overdiagnose or not miss the diagnosis. This is very important. And with this, thank you for active listening, and thank you for always being together. Thank you very much.
Thank you, Sadhana.
Yes, ma'am.
Thank you so much. Very nice and crystal clear lecture. I just wanted to add a few things because as a chair of the REI committee of FIGO, we have recently finished one of our masterclass series lectures on PCOS, and I also happen to be in the pre-PCOS guideline making group. And adolescent PCOS has always been a problem as far as diagnosis is concerned, and we always have been challenged. We really don't know what is really correct. And very recently, in 2020 itself, a new diagnostic criteria has come up for diagnosis of adolescent PCOS, which I feel when we are talking about research and data from especially this part of the world, because even when we were making our guidelines, which are internationally now followed, we always were talking about that this region has minimum contribution as far as data collection and research is concerned. So, and inositols are used in our region left, right, and center, but still we don't have much publications. But what I want to highlight today is the new diagnostic criteria which are there for adolescent PCOS, because this is something which is very important for a region. So the first one is, as you said, irregular menstrual cycle. Now, these are very clearly now defined. This is a paper publication by Alexa Pina from Australia. You can go through the references. And this says that, yes, irregular menstrual cycle of more than 90 days, but this girl should be at least 1 year post-menarche. Or if there are short cycles of less than 21 or more than 45 days, again, between more than 1 to less than 3 years post-menarche. Or primary amenorrhea by 15 years is important, or 3 years post-thelarche. Now, very important, because these are some things which need to be understood and kept in mind. And second important thing is, if we have hyperandrogenism, it must be confirmed by biochemical assay, which we normally do not recommend for the other group. Now, and the third important and most important is that pelvic ultrasound is not recommended within 8 years of post-menarche. So all those criteria which we talk about in post-adolescent PCOS diagnosis, this is for adolescent, it is totally different. And I would like all of us to read this and follow it, because this is something which overdiagnosis or even underdiagnosis is something which is adding on to our problems. Second important thing is that when we are also looking at how to manage these girls, again, there are so many things which are available. Lifestyle, as you very correctly pointed and highlighted and emphasized, is one of the major things. But I think it is more about customization, because this is the most difficult group. Diet is something which we cannot really push. Young children, they want to eat whatever. Parents also are not able to. I face this problem every day with my grandchildren. We knowingly also we are not able to control them. But if we exercise along with them, and if we follow all that what we are preaching, it becomes a little easier. So the family has to also change their lifestyle if they want their children to do better with PCOS. And customization, looking at the lifestyle, looking at the profile of the family, looking at their backgrounds is very, very important, because we say genetics is also 20% part of it. And epigenetics can actually then lead to a genetic predisposition. So all these factors are very important. A very nice and important lecture. I really congratulate you and all the best. It was a treat to listen to you. Thank you.
Thank you. Thank you.
Thank you, ma'am. Thank you, Sadhna ma'am, for a great talk. And thanks, Jaideep ma'am, for the brilliant inputs and very, very informative inputs you have given. So now we move on to the second talk, which is PCOS women and metabolic syndrome. And this deliberation is by a wonderful speaker from Pakistan, Dr. Rubina Sohail. And for this, I would like to invite the chairpersons, Dr. Pratibha Singh. Dr. Pratibha Singh is a consultant OBGYN, a laparoscopic surgeon, an IVF specialist from Bhagalpur, and she is the national coordinator of International Academic Exchange Committee 2021 to 2022, and she's the chairperson-elect International Exchange Committee from 2023 to 2025. And she has organized, she is a brilliant organizer. She organizes wonderful conferences. Lately, she organized a conference at Bhagalpur, which was mentioned by Dr. Sadhna Gupta in the beginning. She has many publications to her credit, and she has the honor of giving the first IVF baby of Eastern Bihar and Jharkhand. So welcome, ma'am. And our second chairperson for this talk is Dr. Harsha Atapattu. He is MS MRCOG. He is a consultant Obs-Gynae, District General Hospital, Hambam Kot, Sri Lanka. So welcome, sir, for on this platform. And over to chairpersons. And I would request Dr. Pratibha Singh to introduce the subject and the speaker, Dr. Rubina Sohail. Over to you, ma'am.
Thank you, Dr. Amrita. Good evening, and I'm really feeling privileged and honored to be among such stalwarts today. And my respectful regards to Chief Guest, Dr. H.D. Pai sir, Guest of Honor, Professor Fardausi Begum, President Safog, Dr. Rohana Hatatatung, Safog Secretary General, Dr. Yusuf Latif Khan, Chairman NCD Committee Safog, Mr. Dr. Pradam Raj Pant, and co-chair of our own Dr. Sadhna Gupta Madam, Dr. Jaideep Malhotra Madam, Dr. Shyam Desai, Dr. Amrita, and all dignitaries from South Asian countries. And I really want to thank the organizers, especially Dr. Sadhna Madam, for giving me this opportunity to chair this important session. And we have just heard a brilliant deliberation on adolescent PCOS by Dr. Sadhna Madam. And PCOS is one of the most common endocrine disease among women of reproductive age, and is associated with many metabolic manifestations such as obesity, insulin resistance, hyperandrogenism, dyslipidemia, NASH or NFLD, etc. And management of metabolic syndrome should focus on risk factor and lifestyle modification and customization. What just now Dr. Jaideep Malhotra Madam was telling is the only recommended intervention at present. Despite of its high prevalence, it is still a neglected entity. And for that, we have a very learned and experienced speaker, Dr. Rubina Sohail, who will be enlightening us on this complex issue. So Madam Rubina, she is SCPS FRCOG, Professor of Obs-Gynae and consultant at Hamid Latif Hospital, Lahore, champion of sexual and reproductive health and rights, pioneer of kangaroo mother care in Pakistan, chair FIGO Committee of Women Facing Crisis, and deputy chair of Scientific Program Committee, FOXY Conference in Paris, which is going to be held in 2023. Past President Safog, and she has given many articles in journals and has contributed many chapters in many books. She has been awarded as Young Gynecologist Award by Safog in 1994, and she is FRCOG Addendum in 2019 for work to improve maternal and neonatal health. So, ma'am, now over to you, and we would like to hear from you regarding your topic. So, over to you, madam.
Good evening, everyone, and Dr. Pratibha, Dr. Harsha. I'm really grateful for this opportunity, and a very good evening to Dr. Leila, Dr. Firdausi, Dr. Jaideep, Dr. Samina Chaudhary, my friend Rohana, Dr. Raj Pant, and Dr. Sadhana Gupta, who have been basically the backbone behind the webinar that is being held today. So the talk that has been allocated to me is extremely important, and I think that the committee chose the topic of polycystic ovarian disease and metabolic syndrome. I think it is a very important issue, because when we keep on talking about polycystic ovarian disease, we forget most of the times about metabolic syndrome. And most of the times polycystic ovarian disease, we are worried about the menstrual disturbance, we are worried about hyperandrogenism, and we are worried about the fertility, which is all happening at a younger age. And when it comes to the thought process about metabolic syndrome, most of the time we forget that there is this entity, and we fail to sensitize the patients and the doctors equally. So this subject is a subject which is basically often forgotten. I would just like to take you all back to the non-communicable disease and to the fact that while in the world we are talking about maternal mortality, and the reason for maternal mortality being those direct and indirect causes, we forget that in the world there's an obstetrical transition that is taking place. And that obstetrical transition is basically changing the cause of maternal death from PPH and hypertension and eclampsia to indirect causes like the non-communicable diseases. Non-communicable diseases are on the rise. 4 groups of non-communicable diseases are actually responsible for more than 80% of premature NCD deaths. And these 4 groups of diseases are cardiovascular disease, cancers, respiratory disease, and diabetes. And if you look at these 4 groups of diseases or disorders, one would think that when we are talking about the polycystic ovarian disease and the metabolic syndrome, actually we can relate to death by non-communicable disease to the metabolic syndrome as well. And that is why I think that one of the very important issues for today for the NCD committee is polycystic ovarian disease. We all know that polycystic ovarian disease is pretty common. It happens in the reproductive age group, and it is one of the most complicated heterogeneous endocrine disorders of reproductive age for the women. Now, when I'm saying that the metabolic syndrome is important, we have to understand that polycystic ovarian disease is associated with metabolic manifestations like obesity, like insulin resistance and hyperandrogenism. And more than 33% of women with PCO end up with having metabolic syndrome. And sometimes there are other women as well. So women who are into the menopausal age group are also predisposed to metabolic syndrome, but PCO has got more than 1/3 of presence related to metabolic syndrome. And the consequences of metabolic syndrome are significant in terms of cardiac disease, in terms of type 2 diabetes, in terms of cancer, sleep apnea, and psychological disorders. The pathogenesis of metabolic syndrome is not clearly elucidated, but there's a lot of emphasis now on the microbiota and the dysbiosis of gut microbiota and the relationship to PCO. Now, when we look at the metabolic dysfunction of PCOS, we realize that more than 50 to 80% of women with PCO have got insulin resistance. There is abdominal obesity, which is a pretty common manifestation, though lean PCO is also present. Hyperandrogenism, in terms of the insulin resistance, obesity, and hyperandrogenism actually form a triangle of forming for the pathogenesis of PCO. Dyslipidemia is happening in more than 70% of the women with PCO, and the metabolic consequences in terms of NAFLD and non-alcoholic steatotic hepatitis and also cardiovascular disease are of significance. Now, when we look at all these metabolic dysfunctions, we have to think of the fact that this is our responsibility to talk to the women when they come to us for PCO about the metabolic syndrome. How does the metabolic syndrome manifest? What are its implications? And what are the ways and means of diagnosis? And it is also a responsibility of the healthcare providers for the polycystic ovarian disease women that we ensure that we check their BMI, we ensure that the blood pressure of these women has to be checked, and we keep an eye on the insulin resistance and the cholesterol and triglyceride levels. Now, we are worried about metabolic syndrome, and the basic worry about metabolic syndrome is in terms of the effect on the heart, on the effect on diabetes, cancer, and as I said previously as well, on sleep apnea and psychological problems. How is it going to manifest? The manifestation is basically in terms of elevated blood sugar levels, in terms of elevated blood pressure, a high triglyceride levels, reduced HDL levels, and a large waist. So many of these things, if you look at them closely, can be done in the clinic. So measurement of the waist, checking of the BMI, measurement of blood pressure of these women, and if we could do a rapid assessment of the blood sugar level are all the things which can be done on a simple visit to the clinician. Now, if you look at the fact and see that these metabolic syndromes, and I said before that it is our responsibility as healthcare providers to make sure that we screen our women who are with PCO. So it is recommended that screening for metabolic syndrome must be done at least every 2 to 3 years. These women need to be counseled, and management strategies need to be put in place, not only in terms of management, but also in terms of prevention of the problem. So the National Institute of Health actually defines metabolic syndrome as the presence of 3 out of these 5 conditions. And the 3 out of these 5 conditions, the conditions are a waist measurement of more than 35 inches, triglyceride more than 150, HDL cholesterol less than 50, blood pressure more than 130/85, and a fasting blood sugar of more than 126 milligram per deciliter. The WHO actually has a little bit different way of looking at it, but it actually boils down to the same fact, and their criteria basically to diagnose metabolic syndrome is 2 out of 5 of these conditions to be present, which is the abdominal versus central obesity, or the waist to hip ratio of more than 0.85, or a BMI of more than 30. Hypertriglyceridemia, more than 150 milligram per deciliter, or a low HDL cholesterol, which is less than 39. A high blood pressure more than 140/90, high fasting glucose levels present, or an impaired glucose tolerance test, or overt diabetes. And microalbuminuria, urinary albumin to creatinine ratio 30 milligram, or excretion rate of albumin is 20 microgram per minute. So a little bit of variation between the WHO criteria and the other criteria, but whatever is feasible, one criteria needs to be put into place. Now, the question arises that if metabolic syndrome is to develop at all, what are the management strategies and what are the things that healthcare providers need to put in place to make sure that metabolic syndrome can be managed effectively so as to reduce the morbidity and also the mortality from the non-communicable diseases which are going to be an outcome of the condition. I find this particular slide very, very important because whatever the interventions that we are offering, and my previous speaker actually highlighted the fact that we keep on talking about weight reduction, but we do not talk about the type of the diet and other things. And you would agree with me that most of the time our women or our patients are not, they do not have enough information. They are not motivated. They are not. They're not in a mood to reduce weight. They feel lost. They are depressed, emotionally labile, and they do not give enough time to realize that this is something which is going to affect their everyday life. So there are very, very important elements of effective interventions for treating metabolic syndrome, and these 4 elements, which are very, very important, are information. So information means that the knowledge that is required by these women and their awareness of the risk that they are facing. Evoking motivation, so we need to make sure that they are motivated, they are empowered, and they make voluntary decisions regarding their management. Cognitive behavioral therapy, we keep on talking about it, but the very important aspect of cognitive behavioral aspects are that recognizing that there is a problem, coping with their emotions, trying to manage them, and then preventing a relapse. And the last thing is training. So making sure that new habits are formed, new activities are performed every day, and we have to make sure that all this that we offer to the patient is affordable, accessible, and attractive to all the participants so that there are no dropouts. And this is really, really a huge challenge that I'm talking about, because all of us who are dealing with these patients day in and day out would realize that these patients are very easily lost to follow-up, and that they would come back to you with worsening of the condition, a greater weight, and greater complications and greater emotional lability. So I have divided the management of metabolic syndrome actually into three basic categories. And the first category obviously is prevention. The second category is the primary intervention, which is in terms of the lifestyle change to prevent or to slow down the progression of the syndrome. And the third is the secondary intervention, which is in terms of drug therapy or bariatric surgery, which is becoming very common. But just a word of caution over here. Before going on to bariatric surgery, it is very important that we make sure that the women are mentally able to cope with the condition. They are emotionally stable. They are motivated to work out. They are motivated to make lifestyle changes. And without the lifestyle changes being put into place to slow down the progression of metabolic syndrome and trying drug therapy, going on straight forward to bariatric therapy seldom resolves the problem. And many a times the women after a couple of years are back to the original position. So I've just tried to put forward the metabolite-related clinical interventions for PCOS because we did talk about it, and Sadhna mentioned that in a bit of detail, that there is an evolving theory of pathogenesis of polycystic ovarian disease. So from that perspective, there are about 6 things which are very important. And as I said before, that dietary intervention is extremely important. But in dietary intervention, we have to make sure that we are not only talking about losing the weight that is in excess, but it is very important to talk about the reduction in the amount of carbohydrates, about the type of diet that women need to do. And nowadays, keto diet, the Mediterranean diet, and there are some other diets which are extremely popular with these women. So talking about not only the reduction in weight, but about the calories and count of the calories and about the type of diet which will be suitable to these women is important. And also is important the fact that about 10 to 15% reduction in weight is actually going to reverse, or it is going to halt the metabolic process, so it needs to be thought about. Then there are other important things, and in those important things are the application of bacteria. So probiotics actually have a greater role to play in terms of polycystic ovarian disease and metabolic syndrome. It is said that vitamin D deficiency needs to be treated in these women with metabolic syndrome to slow down the process. Inositol has been hanging in balance for now quite a while, and there are physicians who are big proponents of inositol, and there are physicians who think that inositol is not here to stay. But basically, there are 2 types of inositol, the myo-inositol and the D-keto-inositol. Both can improve the metabolic profile of PCOS, but for improvement of the metabolic profile of PCOS, they have to be both available and available in the right proportions for the women to utilize them. And many people are propagating the use of metformin along with inositol to help in the metabolic syndrome as well. So this is something which we need to be looking at. I think one of the very encouraging things is GLP-1RA, and this is basically the GLP-1 receptor agonists, such as liraglutide, which has also coming with the name of semaglutide, which has emerged as a new treatment for polycystic ovarian disease in recent years. It is uniquely advantageous from the perspective of metabolic diseases. For example, it inhibits the gastric emptying time, it reduces the intake of food, and it augments insulin secretion. So basically, the semaglutide and liraglutide, they are emerging as new modalities and drugs which help in weight loss. But obviously, they also have to be used with caution, but these are coming up very, very strongly over the horizon. Statins obviously can be used, and they are quite widely used drugs for dyslipidemia, which lower the testosterone level in the patient as well. About metformin, I'm not going to say a lot, but to me, metformin is a very, very important drug, which has a role to play in lowering the insulin resistance, helping in management of weight sometimes as well, and for metabolic management of polycystic ovarian disease. Now, when we look at the management strategies of metabolic syndrome, we have talked about weight reduction. We have talked about the change in the pattern of the diet. We have talked about increased physical activity. The recommended activity is 30 minutes of moderate to intense activity, at least 5 to 6 times a week. Cessation of smoking is seriously encouraged, and pharmacological interventions, which I've talked about, and there are many more depending on the particular condition that the patient has that need to be kept into mind when we are talking about management of metabolic disorder. And we know that for management of obesity, orlistat, sibutramine, and other medications have been in place. But obviously, it will depend on the type of presentation of metabolic syndrome to decide what kind of intervention can be put into place once metabolic syndrome has set in. But I think that whatever the pharmacological interventions or whatever the pharmacological medications, lifestyle modification and weight reduction and weight management and the type of diet still remain the mainstay of treatment, even for metabolic syndrome, because it can reduce the repercussions of metabolic syndrome and it brings a new ray of hope for our women. So just to put it together in the end, we know that NCDs are killers. Metabolic syndrome actually comes into the same category. But as Sadhna said, that when we talk about PCO, we scare the women a lot. So the objective of management of PCO and the objective of prevention and management of metabolic syndrome is to educate the women, to bring them forward, to understand their own body, to understand their own pathology and what are the good ways and interventions to manage this, and to be aware that metabolic syndrome can happen in the future. So at least a yearly visit to a doctor, measurement of the waist, keeping an eye on the weight of the patient, looking at the blood sugar levels, preventing smoking. So these are the kind of things which are going to help, number one, in prevention of metabolic syndrome, but also in early detection of metabolic syndrome if it happens. So prevention is always better than cure, but creating awareness, early diagnosis, and appropriate management can help reduce the morbidity with the metabolic syndrome and improve the quality of life of our women. With this, I think I have come to the end of my presentation, and I would like to invite you all to the FIGO World Congress 2023 to be held in October in Paris next year. Thank you very much.
Wonderful talk, Rubina ma'am. And over to our next chairperson, Dr. Harsha, for his comments.
Dr. Brilliant presentation. Dr. Harsha, I am not seeing. He has joined from the name. So we can invite Dr. Samina and Pratibha for their comments. Dr. Harsha, I'm not seeing. So
okay, Samina ma'am, please give your valuable comments. Dr. Samina ma'am.
It's a very excellent talk from Dr. Rubina. And what she mentioned, that we should be aware about the metabolic syndrome, that which has got a strong linkage with the PCO. And she has mentioned about our lifestyle modification, and that is the prescription will not do the everything, but we should talk with the patient for her motivation. About the dietary advice, she has mentioned many keto diets and other things, but one important thing she mentioned, that we need to change the family diet habit. Otherwise, only girl with PCO, she cannot maintain her habit of food and also the lifestyle. And I think that it's metabolic syndrome, we need to do something for creating awareness for the whole community. Only the healthcare provider will not do anything. So we need to change the environment of the country. That means that in the township or here, it must be the NCD friendly, because it should be if there is no playing ground, and also if there is no working facilities, then how people will do it? So we need to change the whole country profile, that we have to take some policy decisions about the healthy lifestyle environment in the country. Otherwise, we cannot change our lifestyle. So we have to think about this. And I think that this metabolic syndrome, definitely it's a tsunami for ours. So we need to do something together so that we can save these girls from these metabolic diseases. And one small intervention may be introduced in the school health program, that every school there should be some height weight machine, and they will take their weight and they will calculate their BMI. According to that, they will be aware about their weight modification. Thank you very much for the excellent talk from the Dr. Rubina Sohel. I'm very much impressed with your presentation. Thank you all.
Your views, Pratibha ma'am.
Hello.
Yeah, thank you. Hello,
Yeah,
yes. Sir.
yeah.
Hello, yes. Thank you, Dr. Rubina. It was an excellent presentation. And what I feel that this PCOS is becoming a global pandemic, and we have to look after the patient, the female, right from the young age. Once she has been diagnosed as PCOS, maybe lifelong she will remain like that. So we have to make her aware, make that lady aware that how she has to change her lifestyle, because that is the main thrust should be given about the change in their lifestyle, so that she can continue to live in that way, and this metabolic syndrome and metabolic problems which can occur in the later stages of her life will be prevented. So normally what we see in the adolescent age, which Dr. Sadhna madam was also telling, that it is many a times patient herself she'll come and say that I have PCOS. She said, I had gone for ultrasound and the doctor has told that your ovaries are PCOS ovaries. So that is what most of the females, most of the girls, they will come. If they have irregular periods, they will come and they'll say that it is that I have PCOS. So many a times it is overdiagnosed. So first of all, we must diagnose it properly. And if it has been diagnosed as PCOS, then we must look after that. These females should know how to manage their lifestyle, how to change their food habits, and how to have more exercise, and sedentary habits should be reduced in these patients. So very wonderful talk by Dr. Rubina Sohel. It was an excellent talk, and everything you have covered in that. So thank you so much for making me the part of it. Thank you.
Thank you, ma'am. We have come to the end of the session 1, and I thank the speakers, Dr. Sadhna Gupta and Dr. Rubina. And thank you, the wonderful chairpersons, Dr. Jaideep Malhotra, Dr. Samina Chaudhary, Dr. Pratibha Singh. We missed Dr. Harsha. And now I hand over the platform to Dr. Ritu Shrivastava, my friend, for further proceedings. Over to you, Ritu.
Thank you very much, Dr. Amrita. Well, good evening. Now it's time to know about the special perspectives concerning the various countries in South Asia. And to grace the occasion, our chairpersons are Dr. Shyam Desai from India, Sir is obstetrician and gynecologist and endoscopic surgeon, Hinduja Hospital, Nanavati Hospital. He is President-elect Safog 2023-2025. He has adorned many societies as president and chairman in the past. He is honorary professor at Bardia Hospital. We welcome you, sir. Our next chairperson, Dr. Padam Raj Pant. Sir is chairperson, NCD committee. He is head of the department, Obs Gynae at Tribhuvan University, Maharajganj, Nepal. Sir has, his past affiliation is with BP Koirala Institute of Health Sciences, Postgraduate Medical Institute, Lahore, Pakistan. And his membership, he's associated with Nepal Medical Association, Nepal Medical Council, Nepal Society of Obs Gynae, and so on. We welcome you, sir. Our next chairperson is Dr. Laila Arjuman Bano. Madam is Chief Consultant and Head of the Department of Obs Gynae, Lab 8 Specialized Hospital, Dhaka, Bangladesh. Madam is President Bangladesh Perinatal Society and has been the Vice President of Safog. She is Secretary General of Endoscopic Society of Bangladesh. We welcome you, ma'am. Then Dr. Yusuf Latif Khan. Sir is Professor of Obs Gynae in Rashid Latif Medical College. He is most active member of ART team and Life Clinic and actively involved in Hamid Latif Hospital. He is General Secretary of Safog. He is founder member of Society of Gynecological Endoscopy and has published many books and many chapters. We welcome you, sir. Now I request Dr. Shyam Desai to please introduce our first speaker from Sri Lanka, Dr. Jayawardene. Over to you, sir.
Well, it gives me great pleasure to introduce Dr. Indu Asanka Jayawardene, who's an obstetrician and gynecologist in London, in England. He's an MRCOG. He's a senior lecturer in obstetrics and gynecology, Faculty of Medicine, the University of Colombo. He's an honorary consultant obstetrician and gynecologist, professorial unit, Disoida Unit Hospital for Women in Colombo, the Nawaloka Hospital, Nine Bells Hospital, Colombo. Dr. Indu Asanka works as a senior lecturer and academic mentor for both undergraduate and postgraduate students. His research interests include hyperglycemia and pregnancy, preeclampsia and placental disorders, PCOS and metabolic syndrome, obstetric cholestasis, fetal monitoring, severe maternal morbidity, and patient experience of healthcare delivery. He has authored over more than 50 peer-reviewed publications in various international journals, and he's a well-respected medical practitioner in Sri Lanka, and he's eminently, suited to deliver this lecture. May I invite Dr. Indu Asanka Jayawardene to do the needful, please.
Thank you, sir, for that very kind introduction. Let me share my slides. I'm going to talk to you today about the PCOS and metabolic syndrome in a more Sri Lankan perspective. It has been about 15 years since I've been introduced to my mentor on this area, Professor Chandrika Vijayaratna, an eminent endocrinologist and a PCOS specialist, and to the fact that this needs to be.
So are you on any medication at the moment? No. So now we'll put you on vitamins. And what is the nature of
an MDT setting for us to help our patients. So I'm going to dig deep into my clinic and work we do in University of Colombo. But I will take it as the country perspective and take it from there. we all know that polycystic syndrome is the commonest endocrinopathy of young women worldwide. And I will stick to this definition of PCOS, where there is no unique feature phenotype, and any two from PCO, hyperandrogenism, and oligoanovulation, with after excluding other etiologies, will qualify one for a diagnosis of PCOS. Therefore, we have four phenotypes to consider, and these are hyperandrogenism, oligoanovulation, and PCO. The classics, or hyperandrogenism with anovulation, hyperandrogenism and PCO, and anovulation and PCO. And insulin-resistant and polycystic ovarian syndrome, and is closely linked to metabolic syndrome. It's linked to central obesity, hypertension, hyperlipidemia, and insulin resistance, diabetes, as long as 30, 40 years. But very recently, we have been linking this with NASH and obstructive sleep apnea, etc., classic metabolic syndrome. Well, PCO is a lifelong disease, and this is the basis of our management plans and our intervention strategies based on. It is starting from adolescence and goes on to post-reproductive years, and via the initial hyperandrogenism and oligoevolution predominates, metabolic diseases and conditions predominate both in morbidity and importance as one ages on. Therefore, this management needs a multidisciplinary approach. And you need to catch them early, like the eminent speakers before me quite emphasize quite well. So general practice, pediatrics, dermatology helps in there. And then it's not only a gynecologist, there's endocrinology and reproductive medicine that is needs to come in here, and management of a metabolic disease. And most importantly, the psychological burden needs to be addressed. So how can we help? We need a correct diagnosis. We need stepwise process of explaining and tackle the family, respect patient-centered approach, lifestyle modification, and behavioral changes. So in terms of Sri Lankan experience, I will dig into few publications that we managed to do over the 15 years. When we looked at Sri Lankan community prevalence, it was about 6% and in the reproductive age women. The mean age was fairly young. It was much younger than what is at that time published in Western literature. And our PCO symptoms went on, and metabolic syndrome was there in at least 1/3 of the women. What amazed the investigation team was that the culture of silence, which means when we went into the community and picked up the healthy volunteers and did diagnostics, 50% of them, almost 50% of them, had never gone with their symptoms to at least a GP and has never had a diagnosis before. So there's a huge culture of silence where you only diagnose at maximum 50% of the disease burden, and 50% of them were married. So that's the importance of going into the community, which I will try to bring back a little bit on as I go through my discussion. Like I said, there are 4 phenotypes, and when we looked at our data from our clinic population, when we did our publication on that, we had a mean age of 25, and only 50%, or about half were married. There was the major symptoms they came up with: oligomenuria, infertility, and hirsutism, with significant Ferriman-Galway scores, higher Ferriman-Galway scores, and we looked and found that the age of onset or age of diagnosis was somewhere around 18 years. In terms of phenotypes, we had the classic PCOS was the highest with significant contribution from the other three groups. Overall, in our population or the clinic population that we looked at, the PCOS was seen in a much younger age. At that time, it was when we did our publications, it was quite significant finding. Now we know that to be true. We were finding PCOS at much younger age and an early onset of menstrual irregularity and hirsutism compared to the Western, and a greater degree of central obesity compared with the Western, and have a greater prevalence of acanthosis or insulin resistance features in our women, probably because of the skin differences as well. So acanthosis was a major feature that we had in our Sri Lankan women compared to elsewhere. And they were significantly more insulin resistant than the comparable studies done elsewhere. And had post-gestational diabetic group had over 50% of correlates with PCOS, and there was, as like I said before earlier, when we went in with the community prevalence, that was 6% and 50% were undiagnosed previously. So we go back to all phenotypes. When we looked at our clinic population, whether you use the American or WHO criteria, International Diabetic Federation criteria, it really didn't matter. And the phenotype didn't matter either. Approximately, it wasn't statistically significant. Approximately 30 to 40% or 30 to 40% of our group was having, with PCOS, was having metabolic syndrome. So they, 1/3 of PCO in that clinic group was having polycystic ovarian syndrome, whatever the cutoff that you try to do. And it was not different between the phenotypes. It was not different between the phenotypes significantly. So what were the metabolic syndrome issues our women had? Significantly low HDL, suggesting their sedentary lifestyle is contributing, lipid abnormalities, insulin impaired fasting glucose and type 2 diabetes, and abnormal glucose tolerance in a very significant percentage, hypertension up to 25%, and central obesity and high body mass index. And we do need to emphasize that in South Asian women, your cutoff for high BMI should be 25 and not higher, not anything higher. So what did we find in terms of PCOS women compared to the control group? They had higher obesity rates and higher central obesity rates, and significant number of, or at least 1 in 5 PCO were having either impaired fasting glucose or diabetes. So metabolic syndrome, initial stages of metabolic syndrome was well on to the and this was a group this was not a clinic group, this was the community acquired sample, and by the time you got diagnosed, 1/5 of them has been already on their way to developing metabolic syndrome. So at that time, and things have slightly changed for the better, but at that time, we were not concentrating enough on our community prevalence of PCO. So overall, if you had PCO compared to comparable group on your community, you had about twice the chance of having these features of metabolic syndrome. Your chances of having, odds ratio was 2. So in summary, when we talk about the Sri Lankan women with PCOS detected in a community screening setting, had significant metabolic problems and were and the BMI and had age dependent and was often had overlooked the diagnosis and their problems. And when we looked at their psychological profiles and coping strategies, there was significant impairment of quality of life, and that was mainly because of their hirsutism, and the chin hair was the worst culprit in these women. And like I said before, there was a huge problem with coming out or seeking help with for the problem. Only half having sought assistance before this diagnosis was with the community. So what have we been doing so far? So that's the summary of the community and the clinic setup patients that we see in Sri Lanka, and how do we deal with it. We do have the clinic protocols emphasizing weight loss, and at initial stage we like to get them on board with their family for a target of 5% weight loss, and found that this probably is the most feasible target to given over time for women, and it works. And depending on what exactly they need in terms of, we will have to manage with the multidisciplinary team. So maintaining a thin endometrium with the pill, and what we have found in another good randomized control trial done by the pharmacology department of the Colombo medical faculty was that adding cyproterone to the oral contraception pill had no additional benefit in thinning the endometrium and giving regular cycles in these women. So maybe the cheaper version of the oral contraception pill is sufficient and enough. And we do prepare them because we do see them around age 25, our median age, and we do prepare them for if they're married and planning pregnancies. We do the preconception counseling, and we advise them about their metabolic risks. What is the younger group, and what do they need? Their priority need is mostly hirsutism and cosmetic, and regularization of menses. And with pharmacology, this takes time, and that needs to be explained to these women, especially if they're adolescents. And if you prescribe with oral contraception pill, mothers often get worried in our cultural setting. So you need to get everybody on board and reassure them about the safety issues. And this is usually a short term, and it's very safe. That all of that actually increases compliance and increases the chance that you might have in getting these women a lasting management plan, because if you fail first, our experience suggests that it actually doesn't, it does really bad for the patient, because the first visit is probably the most important. And we have looked at psychosocial issues now and found that lifestyle modifications and things are important. I'm going to skip through some of these slides because I'm going to repeat otherwise. We have our clinic protocols, and we find following are the most challenging issues to deal with. The insulin resistance and central obesity, it's very difficult to get these women to shed their weight, and diagnosis of impaired glucose tolerance and diabetes. And once we have followed them up for 5 years, and obviously progression of impaired glucose tolerance, and slightly different from following up gestational diabetics who have been having had a successful pregnancy. Motivation is different, and the compliance is different compared to those. And we do find that obesity cutoff for 25 is the best. Hirsutism, and irrespective of age, hirsutism is a problem. I've had women who are in early 50s, 40s, coming with significant difficulties with hirsutism and stories. And in diagnostics, we find that our total testosterone is good enough test, and it's cheaper than doing free fraction. And commonly, hypothyroidism coexists. So we have a protocol of doing TSH, and we refer to the fertility clinic if they have ovulation, if they are to have ovulation induction. So in summary, PCOS is common and manifests early in South Asians and Sri Lankans in particular. Time and life cycle appropriate management priorities are important. And you should give consistent messages to them with lifestyle modification and messages. And the message that hormone contraception is safe, and hyperandrogenism in these women needs a multi-pronged care approach, and metabolic screening is extremely important. So where do we go from here? So in terms of research, this is the areas that we are leading. We are looking at patient experience, stigma, and how to effectively deliver a multidisciplinary team care. I sort of like that area that's where I'm involved in. And we need to convince PCOS is as an important public health concern to get it into, because it's 50% detection rate if you just wait in the clinics. Unless you go to the community, you are going to miss 50%. And it's the time where you need, it's the best time to approach these women and diagnose them is early. We have 5 colleagues who are looking at metabolic markers in our department, especially the kisspeptin levels, which seem to be higher and seems to be a metabolic marker. If we can develop something like a metabolic marker that can be used in early adolescence, that would be extremely helpful. And we have interesting work that is undergoing in about the genetics of Sri Lankan population in terms of research. I do like to thank the Safog NCD committee for giving me this opportunity and the opportunity to meet the distinguished panel from our region, and my mentor, Professor Chandrika Vijayaratna, Senior Professor in Reproductive Medicine and a world expert in PCOS and expert in the World Guideline Committee, and my other co-authors and other Sri Lankan researchers from whom I have borrowed extensively for this discussion, and my obstetric medicine clinic team at the Soisa Hospital for Women, where I work at the professorial unit. Thank you.
Well, thank you, Dr. Jayawardene. Hello.
Thank you.
Yes,
thank
sir.
you very much.
Yeah. Thank you, Dr. Jayawardene. It was indeed a very elaborate and very revealing talk that you gave about the Sri Lankan women. In fact, in this region of South Asia, we have similar profiles seen in India, in Pakistan, in Bangladesh. And the important thing is to identify the problem earlier, to impress on the patient and her relatives the importance of following the medicines
that we prescribe. Obesity, diabetes, since now this particular region is the incidence of diabetes is going up. So glucose intolerance has to be curtailed, and we have to give them remedial measures to reduce the abnormal endocrine milieu that is over there. Thyroid has to be corrected. We have to make sure that if there is hirsutism, give cyproteron. And in fact, if the patient follows your advice, I've already always noticed that the results are the best. There's some women who start taking the medication, and after a couple of months, they get tired of the medication, and then they stop coming to you, they stop taking the medicines. But recently, I had a patient, a young girl of 17 years old, who showing acanthosis nigricans, severe weight, obesity, and I put her on the medication that we get over here. We put her on Dian 35, and we found to our relief, she even managed to lose weight. She lost 10 kilos and is responding so beautifully. So the patient compliance is most important in trying to, in our treatment of these patients. I congratulate you on a very good talk, and I request my co-chairpersons, in case they have any comments to make, to please do so.
Thank you, sir. Thank you.
So we can go ahead with the next talk.
Yes, sir. Thank you very much, sir. The next talk is by Dr. Rakhi, who's from India. She'll be putting up the Indian perspective. And for this, I invite Dr. Padam Raj Pant to introduce her. Sir, are you there?
Thank you, Dr. Ritu. So, Dr. Rakhi Dhawan Singh is chairperson of Endocrinology Committee of Pcos, vice chairperson of UP State ISAR, peer reviewer for Journal of Obstetrics and Gynecology of India, and she achieved awardments and publication on invited faculty for 350 national and international conferences. Pcos DC Datta Award for publication of Hepatitis B in Women, written chapter in books Pcos, FOCUS, and JEPCOT Gynecology, Fibroid Management, ISAR Express, D down relevance in obstetrics, and GCPR. Hossan Award, their award, ICOG Appreciation Award. Dr. Rakhi, now please.
Thank you. Thank you, Dr. Padam, sir, for that nice introduction. At the outset, I would like to thank the organizers of Safog for giving me the opportunity for delivering this talk today. And for this talk of mine, I would like to thank, one second. I would like to
just click on the play button.
Yeah, started. I would like to thank Dr. Rohana Hatatua from Sri Lanka, the president of Safog, the Secretary General of Safog, Dr. Yusuf Lateef Khan, and Chair Dr. Padam Raj Pant of NCD, and the co-chair Dr. Sadhana Gupta for giving me this opportunity. And it was lovely hearing to Dr. Sadhana Gupta and Dr. Rubina Sohail, and taking home a lot of learning points for today. And I'm going to talk on the PCOD, the NCD, and the Indian perspective of it, sticking on to my topic itself. And the prevalence of polycystic ovaries, there was an article by the Rohtak, Haryana, India state, and it says that polycystic ovarian disease or the syndrome is a major endocrinopathy among the reproductive age group of women, as it is not yet perceived as an important health problem in the world. till now and not recognized to that greater extent. And here it affects to the tune of 4 to 20% of the women of reproductive age worldwide, what we are seeing. The prevalence and diagnosis of etiology, management, clinical practices, psychological issues, and preventions are some of the most important associated with PCOS, what we are looking at it today. And we have learned till now also that the whole world is facing this problem. And this problem has increased to certain amount of the duration because of this COVID coming down and the lockdowns and people being indoors, and not the adolescent kids are not able to go outside for any of the activities. And the online learning overall worldwide, it has increased, and also so in India. And as it is, coming down to the disease burden in India, according to the Indian Society of Assisted Reproduction, ISAR, roughly around 10 to 14% of the Indian couples are now experiencing infertility because of the PCOD. And anovulatory dysfunction is one of the most common and is responsible for somewhere around 40% of the female infertility in India. A study which was conducted in Telangana, India state showed that anovulation usually associated with amenorrhea in about 20% of the women, and PCOS being the leading cause of anovulation in India. Kamath and George, Reproductive Biology and Endocrinology in 2011 also. And polycystic ovarian syndrome is one of the most commonest disorder, yet most neglected endocrine condition affecting female reproductive age group from around 18 years to 44 years. As if it is not handled correctly at the adolescent age group, then we definitely have learned till now that it can lead to metabolic syndrome and its aftermaths, which we have to tackle lifelong. And it is to the tune of 6 to 20%. And coming down to this compilation of the review article, which I have come across, the most common endocrine disorders in the woman, and it is one of the cause for the anovulation in PCOS, and effects to the tune of 50 effects from the age group of 15 years to 45 years of age. And in India, the PCOS is seen to the tune of 1 in 3 women, every woman has PCOS. And there were many articles from Andhra Pradesh, Telangana, Mumbai, and all these had shown the prevalence rate from 9.3% to 22%. And the maximum was in Tamil Nadu, which was around 32%, Tamil Nadu state. It was very high of to the tune of 32%, whereas Kadapa, AP, it was little less to around 6%. When we are comparing the rural India when compared to the vis-a-vis to the urban India, 1 in 10 reproductive age group women are having this PCOS, and 2 in 10 of the adolescent children have increasing trend towards both the urban and the rural areas, the rise in PCOS. Whereas when compared to all the symptoms, we clearly have a demarcation that the PCOS is on a rise in the urban more. Probably the junk food or the easy lifestyle habits which are to be blamed across India. And I think it is with all the children, adolescent, which are not nicely guided, the rightly guidance is not given. And the parents are also to a certain extent being blamed for that, because they are not cooking the food easily. It's easy availability, the workload being more for the parents, and there are no outdoor activities, absolutely, which also could be one of the reasons. And coming down to the incidence, why is it on a rise? As I had said earlier, because of the environmental factors, which also play a major role, the change in the lifestyle of a modern society approach, like easy food ordering habits and the easy junk food, the acidulated drinks could be blamed for it. Academic load with less time for the outdoor activities, the genetic factors, as we have learned till now, play a major role into it. The persistence of physiological hyperinsulinemia during the childhood also plays a major role in the genetic predisposition for the formation of PCOS. There is an existence of fetal programming hypothesis. This states that intrauterine environment is contributory to the future development of PCOS by intrauterine nutritional restriction which results in the changes to insulin level and the insulin resistance within the fetus, in addition to possible epigenetic changes which occur, and the exposure of the fetus to the excess androgen results in programming and changes to the differentiation of developmental tissues, what we see. And that is why when compared to 20 years back and now, there are changes, and there are the adolescents we find more with PCOD, which is coming up. And definitely the EDCs, the endocrine disrupting chemicals, are also responsible for the formation of the PCOS, as the perinatal exposure to the EDCs may contribute to the altered fetal programming hypothesis and explain the significant variability in severity and presentation of the PCOS, right from the pregnancy to the infanthood and then the adolescent age group. This follows through, and because of which all the other symptoms and the presentation of PCOS follow in this child from the adolescent age group. There are various symptoms which are there. If we have not tackled them correctly, then definitely this patient would lead on to, if no correct treatment is given, this can lead to the metabolic syndrome and its complication, which could be coming. And rightly said by the previous speaker, that it is the management of the PCOS which is required to be tackled right from day one. And it is a multidisciplinary approach which has to be taken into account. The gynecologist, the physician, cardiologist, endocrinologist, or the pediatric endocrinologist, if it is an adolescent, dietitian, yoga, or the fitness trainer, psychologist, or the psychiatrist also has to be involved. And these treatment needs to be individualized and chosen to optimize the symptoms and to relieve the patient of it. Because as it is, the patient also has a lot of body image issues because of the obesity entering into with the PCOS, and the psychologist and the psychiatric counseling is required. And it is not only the counseling of the parents itself, the child, adolescent child itself, it is also the counseling of the parents, which is required and mandatory, that the counseling has to be done along with the child, the parents. It is not only the burden of the parent, the child itself, that the PCOS has to be tackled, or the obesity has to be tackled. It is the parents, the family approach to it. The family meal has to be inculcated, that the whole family is responsible for it, and the correction has to be done at that level. There are various goals and therapies in the PCOS treatment. The short-term issues have to be corrected. And then once they are not addressed to the short-term issues, then the long-term goals would definitely be present, and they have to be dealt with to decrease the amount of metabolic syndrome or the other future problems which can occur because of not treating the short-term goals of the PCOS and not meeting the ends. And coming down to the studies, there is a study by the Abhiyan PCOS Consortium of Multidisciplinary Strategies for the Management by Dr. Ramavidya and all at Mumbai. And it's the 2021 study, which says that NCD today are the major cause of the global disease in morbidity and mortality, more so in the low and the middle income countries like India. Between the years of 1990 to 2016, the disease burden in India due to NCD increased from 48% to 75%. In 2013, India became the first country to be part of the global monitoring framework for the major NCDs. And according to this, to tackle the major health problems in India, PCOS and inter-institutional collaboration between the government and the non-government sectors is an imperative precondition which has to be taken into account. The early experience of Abhiyan PCOS shows that we are on a learning curve, but the declaration of One Nation, One Health by Niti Aayog or Government of India offers both a challenge and an opportunity for advanced multidisciplinary, multi-speciality, and systemic management of PCOS. The Abhiyan PCOS Consortium also states that the obesity and the diabetes are two known associates of PCOS. The Government of India has launched National Program for the Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke since 2010. It was implemented for the intervention up to the district level under the National Health Mission. NPCD PCS has a focus on awareness, generation for behavior and lifestyle changes, screening and early diagnosis of persons with high levels of risk factors, including obesity and diabetes, their referrals to higher facilities are appropriate management of non-communicable diseases. Population level screening of non-communicable diseases was initiated in 2017 by government, and so far 215 districts have implemented screening, and till one were screened for common NCDs also. And the Government of India, the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke has been taking out the handbooks for the counselors repeatedly every year. And it has been teaching to all the PHCs, the CHCs level, and the program has been taken up at length. And PCOS and NCD control program, according to them, they say that it is the role of the counselor which plays a major role. We as a gynecologist in the clinic, we need to identify the risk factors and help the patient out. As soon as we identify, we need to counsel them and explain them the disease burden, what it is, and take an adequate measure. And in the community, to organize the health promotional activities, provide awareness about the risk factors, and the prevention also needs to be done hand in hand. There are various levels of prevention. It could be, the first one could be the primordial prevention, which is the preventing the emergencies of risk factors in the population group. The primary prevention, which would be like the action is taken before the onset of the risk factors, and an effective communication strategy has to be evolved by counseling all the women's group, farmers, the youth group, the factory workers, the school population. We need to target the population and explain them in the group. And secondary prevention would be the screening and the medical examination and the referral for the early intervention for the obesity, high risk blood pressure, or any of the excess weight gain problems, or reduce the risk factors for becoming the complication and developing of the NCDs. Tertiary prevention would occur when the disease has advanced beyond the early stages, and intervention and involved in the stages include the disability and limitation and rehabilitation for the counselors, has a limited role in a tertiary prevention. Government of India, there was another paper which was taken out by the Government of India, Ministry of Health and Family Welfare, Department of the Health and Research. According to this, in 2018, the polycystic ovarian syndrome in women, the questions were asked, will the Minister of Health and Family Welfare will be pleased to state? The questions which were asked were whether the large number of women in the country are suffering from polycystic syndrome, and if so, the details, what are they? Whether the government is considering to take any steps to control this, if so, the details therefore, and the time by which and the said steps are likely to be taken, and if not, the reasons, what are they? The government has replied to this, stating that for the first question was, yes, as per the studies carried out in India, the prevalence of polycystic ovarian syndrome ranges from 3.7 to 28%, varying in the age group of 12 to 40 years. The government also recognized and said that Indian Council of Medical Research and National Institute for the Research in Reproductive Health, Mumbai, runs a holistic clinic of PCOS management stations to address various dimensions of the disease. This multidisciplinary clinic was inaugurated on 30th of April 2016 for generating evidence of the magnitude of the problem, identify the key physiological causes, including the genetic predisposition, and developing models of holistic management and further upscaling. The Government of India has started recognizing PCOS as one of the NCDs, and which is very important to curtail it down, because India is emerging as a diabetic capital of the world, and PCOS is one part of the NCDs which has to be tackled. Here, the prevention and counseling plays a major role, and the only mode of prevention is the prevention of obesity. Women with PCOS need to be counseled about the condition itself, along with its association, especially metabolic and cardiovascular. a properly informed patient would be better equipped to choose between different modalities of treatment, especially for the prevention of long-term consequences which would follow from the PCOS. There are many various reducing factors for the non-communicable diseases in the primary healthcare centers, which the government is working, and the private FOXI is also working on it, as we have heard our FOXI president, Dr. Rishikesh Pai, telling that NCD is one of the PCOS is one of the major factors which he wants to tackle it, and he wants to take up further to work on it on his Yatra work, also what he had mentioned. And there are various training modules and the medical officers, which the government of India and Ministry of Health and Family Welfare is working on it. There are various camps which are organized in the schools. And here in India, the Modi government has also started putting up the open gym in the parks everywhere around, which most of the females who are not able to go to the proper gym and work out on it, they can go to the parks and do all the homeworks. And there are various other programs of the NCDs which are in place to decrease the risk factors of NCD and target to be achieved by 2025. And I was also being associated with the Ministry of Health and Family Welfare. I have been taking the state training of the trainers for the NCDs. And here the adolescent health program has included also the PCOD and recognized as one of the main important problem, which has to be educated to all the adolescents. Thank you all.
Thank you, Dr. Rakhi, for a wonderful insight into the Indian scenario. I request Dr. Padam Raj Pant to give his concluding remarks. Sir.
Thank you, Dr. Rakhi, for your elaborative presentation on perspective of India. Congratulations, very nice presentation. Thank you.
Thank you, sir.
Our next speaker is Dr. Farhana Diwan from Bangladesh. And I invite Dr. Laila Arjumand Bano ma'am to please introduce Dr. Farhana.
Thank you. Sorry. Thank you very much. A special thanks to Dr. Sadhna for inviting me to join this very much optimizing session. So, and I am very much delighted to talk about Professor Farhana Diwan. She is our most eminent and very energetic, active member of our society. She is now the President-elect OGSB, Deputy Secretary General Safog, Head Department of Obstetrics and Gynecology, Ibn Sina Medical College, Professor of Obs and Gynae in different medical colleges, and Deputy National Coordinator, FIGO PPH Bundle Project, Bangladesh, 2020 to till now, and Deputy National Coordinator, FIGO PPIOD Project, Bangladesh, 2015 to 2020. Actually, she has done many projects on behalf of our Obstetrical and Gynecological Society of Bangladesh. Thank you very much, Dr. Farhana. Please present your paper. Thank you.
Thank you very much, Madam, for your kind introduction. So I'm sharing my screen. So, respected chairpersons and dear audience, I'm really delighted to be able to present in this August gathering an esteemed platform. For that reason, I would like to thank the President of Safog, Professor Rohana, and of course, my friend, Dr. Sadhana, for giving me this opportunity. Thank you, ma'am. And so, dear audience, we have been listening to this PCO problem for a long time till now, from 5:30 p.m. Bangladesh time, and it is more than nearly 2 hours. And we have heard from other presenters the magnitude of the problem and what needs to be done. I have also learned a lot. So I would like to, talking about Bangladesh, I would like to present a few papers which have been studied, a few studies which have been done since 2013, and up till now there have been some papers which have looked into the different aspects of PCOS. So during my presentation, after a few introductory words, I will go into the studies which have been done in our country. And PCOS, everybody has mentioned that it is a heterogeneous androgen excess disorder, and it is associated with significant reproductive morbidity, including infertility, abnormal uterine bleeding, and miscarriage. And prevalence also, we have heard that it is 5 to 18%, and it is about 4 to 20% women of reproductive age, and infertility, it is also a similar incidence. Though PCOS affects women at any stage, the manifestation may develop in adolescence, but may not be diagnosed until well into adulthood, because there is some problem in the diagnosis during adolescence, because the diagnostic criteria is also very, very difficult in the adolescent period. Normal adolescent physiology, including irregular cycle and acne, they may mimic the symptom of PCOS. That is the problem. And also, besides, multifollicular ovaries are a feature of normal puberty. And so that is the problem why diagnosis may be late. But identifying and treating adolescent with PCOS is of prime importance, because as adult women, PCOS have a 10-fold increased risk of developing type 2 diabetes and 2-fold increased risk of developing metabolic syndrome. For that reason, it is very important to diagnose it as early as possible. And I would like to echo with Dr. Shyam Desai sir, that he has mentioned that, what about the compliance? We are giving treatment, but how the women are complying with it? And I think that Dr. Rakhi's that slide where the women were having the exercise in open field because they're not possible to go to gym, I think it's a very excellent idea. We can also think about it in Bangladesh. So diagnosis is challenging, and we know it is the classical feature. Everybody has talked about it, and everybody has also talked about the diagnostic criteria, which has come up at different times at from different organizations, and now we have established it. And this is the pathophysiology of PCOS. And in case of insulin, we know the relationship with insulin. That is, in PCOS, there is insulin resistance and hyperinsulinemia. And this insulin stimulates ovarian androgen production, and there is reduced sex hormone binding globulin, leading to disordered FSH-LH. This leads to hyperandrogenism, anovulation, and ultimately there is PCOS in these women. So these are the symptoms of PCOS, and these are the problems which we face in these girls and adolescent girls, and also the women of reproductive age. And this is the difference of the ultrasonography finding in normal ovary and a PCOS ovary. So I'm now coming to Bangladesh perspective. I will talk about 4 studies which have been done in different times, and I think you can gather from these studies what is the scenario of our country. So the first study was done, I'll mention the first study. It is a clinical metabolic and hormonal profile of 175 women with PCOS, which is the latest study in 2021. And then I will talk about 500 cases of PCOS, which is done over a period of 4 years in a tertiary care hospital. Then I will talk about women who have been attending the OPD of BSMEMU, that is University of Bangladesh, Bangabandhu Sheikh Mujib University. It is a tertiary referral specialized hospital. And what is the type of women who have, type of patient who have come here? And lastly, I will talk about a study which was done looking into the mental health. And I think this is something new, which none of the presenters very much mentioned up till now. So this is the first study which is done in Mymensingh Medical College, where they looked into the clinical, metabolic, and hormonal profile of adolescents with PCOS. And here they found that features of PCOS vary greatly, and data is about this is not so much apparent, so they have done this study to see the knowledge there. This is a cross-sectional study conducted among adolescent newly diagnosed PCOS attending a tertiary hospital, and this is a profile of 175 participants. The mean age was 16.8 years, and among the menstrual irregularity, Oligomenorrhea was found to be in 88%, and more than one quantum, nearly 30% where PCO was common in the first degree relative, and they had it, about 12% had first degree relative with type 2 diabetes. And more than 77% of these cases had acanthosis nigricans, which Shyam Desai sir also mentioned. And majority were overweight, and some of them were underweight as well. And there was most of them, we also know that, I think the doctor from Nepal was mentioning about the abdominal obesity. And 1/5 had pre-hypertension, and 1/4 had abnormal glucose tolerance. And this is the metabolic syndrome was present in 42%. And higher body mass index and presence of hirsutism was also associated with higher risk of metabolic syndrome. So they have concluded that clinical metabolic and hormonal profile of Bangladeshi adolescent highlights the factor and needs for clinical vigilance and their responsibility to metabolic disease. That is, we should address this issue very seriously. I will not go into the discussion because it compares with other studies done in other countries. Now I am going to mention the second study, which was done in a tertiary hospital where 500 cases of polycystic ovary patients were seen over a period of 4 years. So this is a cross-sectional study carried out in Department of Obstetrics and Gynecology of Sigdar Women. It's a private hospital, big hospital, from 2013 to 2016. And objective was to find out the clinical presentation, endocrine status, and menstrual abnormality, and also what was the sonography finding. The first they studied 1,600 patients with infertility, and among them 500 cases was found to have met the criteria of polycystic ovary. So here there was they studied about the infertility and found fertility that primary. And here we found that in the first study the age range was 16 years. Here the age range is about 25 to 35 years. And the duration of infertility has found to be 5 to 18 years duration. And among the menstrual disturbance, 78% patient had women had menstrual disturbance, 18% had amenorrhea, and 50% had oligomenorrhea. So you can see that among the studies, these are varying. So it is a study finding, of course, and there may be other confounding factors which may be responsible for this variation. So obesity was found in 42%, and 42% were obese and 46% were overweight. So the prevalence of PCO was 31%, and among them we have already mentioned about the infertility and the menstrual disturbance. So this is the third study where they looked into the prevalence and characteristic of PCO in women who were attending the BSMME Bangabandhu Sheikh Mujib Medical University, and this was done over a period of 1 year, and about 100 cases were studied. So it was done in 100 cases from August 2018 to July 2019 in the OBGYN department of BSMMU. This is a big referral hospital, which is the biggest medical university here. Then also, they also looked into the clinical, biochemical, and hormonal profile of this patient. And so it was a cross-section study, and the clinical biochemical profile was seen. The prevalence of PCO was 6.11% in the gynecological patient who were visiting, and 35% among infertile women. And the BMI was 24.66, and the mean duration of infertility was 5.17 years. The prevalence was 15% of prevalence of metabolic syndrome was 15% in this study. And they also showed that there was menstrual irregularity was the commonest problem in these women. So the study showed that most of the women with polycystic ovary, the subject were present with oligomenorrhea, and also they also found that central obesity was common and hirsutism was common. And these obese women had more severe ovulation dysfunction. So we can see that there are some variation in the different studies done at different times with different study population, but all these studies that took the different criteria, the criteria which met for the polycystic ovary, it was taken. So the prevalence, this is the last study which I want to mention, is the prevalence and associated risk factor for mental health problem among patients with polycystic ovary. This is a cross-section study which was done. This was a sort of Google form. They took it in the Google form, not in any specific hospital. And this was done in this university. They did it from the university. They performed an online cross-sectional survey among participants with PCOS, and we used structured questionnaire to collect the social demographic information, and they applied patient health questionnaire, generalized anxiety disorder. This is actually, we are not very acquainted with this, and they use different scales to see the psychological aspect. And this applied the statistical tools to perform the data interpretation and to evaluate the prevalence of mental health disorder. And the result was found that prevalence of loneliness, generalized anxiety disorder, depressive illness were about 88% and 60% respectively. And mental illness, moderate and severe cases were 39%, 18%, and 14%. And also there was the incidence of loneliness among them, and 39%, 23%, 26% for generalized anxiety disorder, and 35%, 18%, 7% for depressive illness. So obesity, financial condition, physical exercise, food habit, daily water consumption, birth control method, and long-term oral contraceptive contributed. They found that these were some contributory factors which with PCO who suffered from these mental illness. I think that this is because something it is new. There is scope for further study in the mental illness issue. So they concluded that high proportion of women suffering from PCOS experienced mental disorder in Bangladesh, and several socio-demographic lifestyle-related factors were found to be associated with poor mental health. And PCOS itself is a condition that favors poor physical and psychological health. So actually, this group, they recommended that we should do the public awareness and healthy lifestyle. And I think this is very well depicted. This was very well depicted in Professor Rubina Sohel's elaborate presentation. So this was the last study which I wanted to present. And now I would like to just mention a few words about the activities of PCOS in our country. We have a PCO club which was established a few years back, and Professor Laila Arjuman Banu is the chairperson of the president of this. And a large number of activities have been done, because since the club was formed, actually we had the lockdown. For that reason, mostly they did the webinars, and their adolescent-friendly activities have been done. And in our country, we have got the adolescent corners in different hospitals. The government has made this adolescent corner in different hospitals, and they are working. And very recently, we are trying hard to look into this matter. And number two, the second thing is that different awareness program have been done, and especially the problem with the adolescent has been looked into, and we are trying to this. And a large number of, I think, something regarding the question answers and direct communication with the public has been tried in this regard, and I think that they are also getting good results. So I would like to conclude here by saying that in Bangladesh, things are coming up. We are getting girls with adolescent with obesity, and adolescent with metabolic syndrome, and adolescent with PCOS, and also the infertile women who are PCOS women who are suffering from infertility as well. So I think that this was a wonderful platform for all of us to share our experience and learn together. So I would like to conclude here. Thank you very much.
Thank you, Madam, for your valuable insight into Bangladesh scenario. I request Dr. Laila to please give her concluding remarks.
Thank you very much. Actually, I must congratulate Professor Farhana Dewan for a very brief and informative presentation. Thank you very much. You have mentioned about the 4 studies, and I want to add with her that the PCO Club of Bangladesh, where I am the president, we have done many webinars and we have done the interviews of school girls and college girls and also some garments and some teachers of the college and schools. So I think it is a continuous process and we will look after that. So I am not stating any theoretical aspect because all the speakers, they have nicely described about PCOS and the metabolic syndrome. Just I want to give emphasis that PCO with infertility and PCO with obesity, we are dealing with those. But PCO with metabolic syndrome, which I think it is somehow neglected, but we should look after that because the complications are so dreaded that the girl, when she reaches the age of menopause or reaches the reproductive age, there will be many complications like the hypertension, diabetes, dyslipidemia, like this. So already mentioned the 33% of the metabolic syndrome is in case of PCO patients, and they are characterized by obesity, insulin resistant, hypertension, dyslipidemia, and hyperandrogenism. Hyperandrogenism, and these all they are the risk factors. They are the consequences like this. I just want to mention some newer concepts like there is a syndrome called hair and syndrome, which denotes that here HM is hyperandrogenism, IR that is the insulin resistant, and acanthosis, AN. So this syndrome actually described all the characteristics of the metabolic syndrome. So I think we can think about it. And there is some development in the pathogenesis. The small chapter is described by I think the presenter from Sri Lanka. Actually, there are some predictors of the metabolic syndrome. Like first one, I can tell that the follistatin, serum follistatin, it neutralizes the active inactivity, which inhibits androgen production. And follistatin also inhibits the follicular stimulating hormone secretion, folliculogenesis, increased IR, and diabetes mellitus. Another is the adiponectin. It is also an important predictor of metabolic syndrome. And ghrelin, peptide hormone associated with insulin resistant and diabetes mellitus. It inversely relation with hyperandrogenism. So in case of PCO and the metabolic syndrome, we found that the adiponectin is less and there is increase of the leptin. So these 3 or 4 predictors, they are very important. I think much studies should be done to know the etiology, because we know still we don't know the exact etiology of PCO. Now it is genetically determined, and also they said that there are some predictors. So according to, there are some criteria also in the various centers, amongst them the NCEP criteria, that means the National Cholesterol Education Program. And they criteria for the metabolic syndrome is central obesity, already we know, central, the serum triglycerides, systemic hypertension, and increased fasting plasma glucose. So another thing is important that metabolic syndrome should not be diagnosed before age of 10, because there are some confusing characteristics or some confusing outcome will be there. So it is better to done after 15 years. And there is another information that for 1 centimeter increase in waist circumference, the incidence of MS, that means the metabolic syndrome, rises about 7.4%. And for every increase of 1 milligram per deciliter triglycerides, there is increase about 1.13% of the metabolic syndrome. Another is the visceral adiposity index. It is calculated by a formula using waist circumference, BMI, triglycerides, and HDL levels. Actually, all these, I think these new things are coming, and I think we can discuss and we can study these things. And about management, everything has been done. Only the use of metformin, it should become last, and the exercise already done. And we should aware about that in metabolic syndrome, cancer is very one of the complications, and we should look about this. So I think I have to told many things, and I again give my gratitude to Dr. Rohana Hatatua, Dr. Yusuf, Professor Yusuf Latif Khan, especially Sadhana, because she has repeatedly written me, and also the other team members of her. They have always communicated with me. So thank you very much, and I think it's an excellent webinar. Today's, though it is slightly time long, but it is excellent. The information we got, it is actually newer to us. So thank you very much. I request to Sadhana to please have this type of webinars in future, and I think you can do that. A special thanks to also Farhana for stating our Bangladeshi perspective. Thank you very much.
Thank you, madam. Thank you, madam. Now, our next speaker is Dr. Hima Rijal from Nepal, and I invite Dr. Yusuf Latif Khan sir to please introduce her.
Ritu, you can go ahead with this thing. We are late. Ritu, you go ahead with the intros because already we are late. So Yusuf is there. Yes, I think there may be some issues. So short introduction.
Dr. Hima Rijal is Assistant Professor, Department of Obs Gynae, Institute of Medicine, Tribhuvan University Hospital, Kathmandu. She has plenty of publications on varied subjects in her name. She has received training in various subjects. Now over to you, Dr. Hima, for delivering your talk and perspective of Nepal. Ma'am, are you there?
Yes, ma'am. Hello, thank you. Thank you for the introduction, ma'am. Hello?
Yes, please continue.
Thank you for the introduction. And I'd like to thank Safog for giving me the opportunity for this presentation. And I'm going to start PCOS perspective, Nepal.
Make it a slide, full screen.
So as we all have discussed, it is a heterogeneous disorder with uncertain etiology and has been described as polygenic and multifactorial. It affects 5 to 10% of the female worldwide, and it is defined and diagnosed by a combination of signs and symptoms of androgen excess, ovarian dysfunction, and PCOS morphology in ultrasound. So based on geographical segregation, people vary in physical, social, and behavioral features due to natural selection and environmental adaptation, which influence the phenotype of the disease. Race and ethnicity affect clinical presentation of PCOS due to different genetic, environmental predisposition to endocrine and metabolic aberrations. So as we all know, we have been using the different criteria for the diagnosis of PCOS. In Nepal, most of the studies have followed the Rotterdam criteria. And this graph shows the prevalence of polycystic ovarian syndrome highest in the Asia compared to the other part of the world.
Your slides are not moving. And make it as a PowerPoint mode, please.
Sorry?
Make it full screen first and then
full screen and then move the slides.
Yes,
now it's done.
Yes.
Make it full screen also. Click on that.
Yeah.
Double click on that.
Done?
Yeah, it's okay. Yes. Please
It is
continue.
not yet done.
Still it's showing on the screen.
Otherwise, on the upper taskbar, there is also a slideshow mode. Animations, next to animations, you can click on that also. If this is not happening from down.
I think it's quite visible. You can continue with this.
Visible now?
Yeah.
Sorry?
Yes.
When you continue with this mode only, it is clearly visible.
Okay, thank you. So the prevalence of menstrual disorder varies 75 to 90% depending on the age of the woman and criteria used to define menstrual irregularities. We have reported the percentage is 78 to 86% in different studies done in Nepal. The hyperandrogenism is the central feature of polycystic ovarian
One
syndrome.
slide next, you have to do it.
Sorry?
You need to
Click on the next slide.
slides also.
Actually, your
click on the
slides are
slide
not
on the
moving.
website.
Your slides are not moving, so you press on the next slide.
Ma'am, just
On
go
the-
to normal mode. If you are on a presentation mode, exit from that. Yes.
Yeah, it's
Click on the one time, just click on the 11th slide and it will move by click on the downward. Yes, ma'am. Now please go ahead, ma'am.
So hyperandrogenism is a central feature of polycystic ovary. 58 to 82% of the hyperandrogenism women are polycystic, depending upon the diagnostic criteria. We have hirsutism reported in 3.7 to 33%, and acne is reported in 13 to 44% of the cases, and acanthosis is reported in 33%. And we have biochemical hyperandrogenism is reported in 82% of the cases. And we have polycystic ovarian morphology. Polycystic ovarian morphology is seen 3 to 4-fold more prevalent in adolescents than polycystic ovarian syndrome. And the polycystic ovary is reported to be 60 to 78%. And there is a wide variation in reporting of infertility in PCOS. We have 22, 88, 81% of the cases of infertility reported in various studies. Obesity is long being recognized as one of the features of PCOS. 40 to 80% of PCOS women are overweight or obese. We have 6% reported to be underweight, 22 to 36% is reported to be overweight, and 33 to 61% are reported to be obese. And coming to metabolic syndrome, it is a wave of risk factors associated with diabetes, cardiovascular disease, showing a 30 to 40% probability of developing a disease in the years to follow. Insulin resistance, hyperinsulinemia contribute to hyperandrogenism, which categorize both PCOS and metabolic syndrome. And obesity, which is common to both, amplifies the risks. And we have prevalence of metabolic syndrome is 47.1%, which is a value compared to high than the other part of the world. The study was done in 2022, and the diabetes along with PCOS was reported to be 0.5 to 8%. And hypertension associated with polycystic ovarian disease was reported to 1.6 to 4%. And this is the graph which shows the increased trend of obesity in our part of the world, where we can see the increasing tendency of obesity and overweight. From 2006, it was 9%, and it has gone up. And in 2016, it is up to 22. So the occurrence of polycystic ovarian in urban compared to rural area was 67, and compared to 33% in the rural area. This shows that the polycystic ovarian is more prevalent in the urban area. And we have none of the study has reported the endometrial cancer or psychological issues in case of the PCOS. So what are our concerns? So our concerns are like PCOS being considered as a lifestyle disease. Less attention is given in the social educations. We have high tendency of having food which are rich in carbohydrate, fat, rich, refined and processed food with low dietary fibers. There is reduced physical activities, stressful lifestyle changes. Moreover, the threat of abdominal adiposity, as reported in other South Asian population, is commonly seen in Nepali population too. So what is the scenario in Nepal? A recent surge in prevalence of PCOS in younger women in Nepal has been growing concern. Childhood and adolescence obesity is also a rising trend. And even though the early diagnosis and management is critical for the long-term outcome, we have certain group of patients who come late for the diagnosis. It may be due to the lack of awareness or sometimes the rural people, they don't seek the medical attention till they have major problems like infertility. And in management part, like we don't have though the people take the initial management, but the other surgeries and medical treatment for weight reduction are not that much cost effective for the poor people. And for the follow-up, the lacking part is the follow-up for the PCOS patient. For that, the patient doesn't want to continue follow-up for the longer period of time, as we need to do follow-up in PCOS patient, and that's why the morbidity like CA endometrium couldn't be follow up, as the patient couldn't be follow up for the long period of time. So what will be the future direction in our setup? The strongest steps towards prevention of obesity related morbidity should be initiated through cross-disciplinary approach, integrated management of risk factors. We should prioritize the health educations, like if we increase the awareness of the obesity and its consequences at the school level, then it will be beneficial for the future. And we should use various sector like media and education sector to emphasize the health related educations, and we should promote the outdoor physical activities in the school curriculum. And we can also modify the increasingly obesogenic environment, like we can stop advertising the junk food advertisement which we see in the boarding in the streets and while going for shopping. So we can do that, which also help us in improving the dietary habit, and moreover increasing access to the diet and healthcare service will be helpful. So in our experience, like we did a study, we studied a 223 infertile women in our hospital. We enrolled them as per Rotterdam criteria, and then we did hormone profile and scanning, TVS, and we found that the age of the patient was 20 to 37. Oligomenorrhea was seen in 87.59%, and the mean duration of conception was 30.34 months. And we have normal BMI in 43%, whereas overweight was seen in 42.6%. Waist to ratio was more than 0.8 in 53% of patients, and hyperandrogenism, the hirsutism was seen in 39.9%, acne was in 27%, and androgenic alopecia in 1.3%. We found that significant difference in testosterone and estrogen in those who have hirsutism. Testosterone and LS-FSH level was found to be elevated in those patients who have acne. LS-FSH level were found higher in patients who have waist-hip ratio more than 0.8. And there was significant difference in estrogen in different category of BMI, with obese category presenting with a high level of estrogen. So coming to the summary, the prevalence of in Nepal, it is 9.18% with a mean age of 24 plus minus 6 years. Hirsutism was 3.7 to 33%. Infertility was reported to be 22% to 81% in various studies. Obesity is long been recognized as one of the features of PCOS, and it has been reported as 33 to 61%. And the prevalence of metabolic syndrome was 47.1%. And the adolescent and urban population are mostly affected by obesity and PCOS. The recent surge in prevalence of PCOS in younger women in Nepal has been a growing concern. And the larger scale study helps in finding the data and help in management of the disease in future. Thank you.
Thank you, Dr. Hema, for the valuable insight into Nepal scenario. So with this, we come to an end of a very informative and wonderful webinar. I feel honored and privileged to propose a vote of thanks on this special occasion. I would like to thank President Dr. Rohana, Secretary General Dr. Yusuf Lateef Khan, Chief Guest Dr. Rishikesh Pai, and Guest of Honor Professor Firdausi Begum for their gracious presence and words of wisdom and blessings. I'm extremely thankful to Chair Dr. Padam Rajpant and Co-Chair Dr. Sadhna Gupta for organizing this wonderful webinar and their guidance. I'm thankful to the chairpersons for their valuable opinions and valuable insights into various perspectives. My special thanks to the speaker for their informative and enriching talks. The wonderful perspective put by speakers for their countries have given us a valuable insight. I will ever be so grateful to Dr. Amrita ma'am for her guidance and support. And I'm extremely thankful to the organizing team, Corona Remedies. Their sincere and hard work has made this webinar very successful. So with this, we come to an end. Thank you very much for being with us. Thank you. Thank you.
Thank you.
A lovely webinar and take-home messages academically. And I'm thankful for the Safog team, Dr. Rohana Hatatua and Dr. Yusuf and all the senior delegates, esteemed faculty who are there for giving us the opportunity, and Dr. Sadhna Gupta madam also for giving me the opportunity for Indian perspective. Thank you.
Yeah, she had a certain emergency, therefore she had to leave.
Okay, okay. I was looking for her.
Otherwise, she's always there.
That was the reason.
She's always there.
She's always there till the end.
No, there was some emergency in her hospital, therefore she had to.
Thank you, Ritu madam.
Thank you so much.
Nice,
Thank you very much, ma'am.
It so well.
It was such a wonderful webinar. We get to meet people from various countries and get to know about them. It's
And
certainly
we
very
also
valuable.
can share experience and know about
Yeah,
it.
that is very good.
It
That
was
is
lovely
wonderful,
hearing
actually.
all the different countries and the way ahead.
Thank you. You know, Himi was mentioning, her name is Himi. She was mentioning that you, for the junk food, you stop the ads. I was just laughing that if you stop the ads, the junk food will not stop. People will not stop taking junk food. Have to do something more strict.
Awareness has to be created, actually. And this should come from the
has to come right from the school and middle school, not even the higher school, the middle school. And while giving the awareness talks, I sincerely feel that the parents need to be more aware.
That is very true.
And, because they are the ones who have that
urbanization.
Parents have a great role to play. Actually, in South Asia, family bonds are so great. So parents definitely have a major role to play in this.
And that's what the parents, because parents are